coordinators, none other than Dr. Beena Bansal and Dr. Preeti. I know both of them don't require introduction to this audience, but I still have the honors of doing the needful. So Beena has been one of the backbones of the meeting, the quiet person who's been doing a lot of work. All these lovely slides that you're seeing up here are actually Beena's brainchild. I mean, my artistic value is absolutely negligible, to be very honest. So Beena is, yes, the founder and director of Door to Care Endocrine and Diabetes Clinic, Gurgaon, the president of Saksham, number of areas of interest, but her most recent meeting, which was humanizing medicine, gives us a totally different narrative as to how do we actually look at medical care. And as I said, narrative medicine and medical humanities and behavioral sciences in chronic care medicine is what I think is really her forte. Thanks, Beena. Thanks for being a part of this fantastic journey. And the next the next coordinator is Dr. Preeti, a person whom I've recently had the good fortune of knowing, to be very honest, over the last few meetings. I always say that COVID has had its silver lining, and the silver lining of COVID has been that I've made many more friends during the last 2 years. So she's a professor at the Department of Endocrinology, SGPGI, Lucknow, a great amount of work, number of publications, and of course, a fantastic speaker. Over to you, Preeti and Beena.
Thank you, Shaila. And as I said, this whole organizing team, the brainchild of Shaila, needs a lot of applause for having such a good program. We had a good first day, and we hope to have academically sound as well as a very interactive second day as well. So to begin, today's first session is diabetes in women. All of us know that diabetes is important in certain aspects and which will be dealt by various speakers in the coming forth. And for this, we have chairpersons, none other than Professor Ashok Kumar Das, whom I know personally and have had the fortune to work with him as well. And he is a consultant physician and endocrinologist at New Medical Center and Sri Aurobindo Ashram Nursing Home, Pondicherry. And he was former professor and head of endocrinology at JIPMA. He's former director of Indian Institute of Diabetes, Trivandrum, and has had a vast experience working overseas and has inculcated the same values in his department where he was a former head. He has numerous publications, about 200 publications in international and national journals. And the positions, important positions he has held previously is past president of API, past president of RSSDI, Diabetes in Pregnancy Society of India, and past dean of Indian College of Physicians. And our second chairperson for the morning session is Professor Datta Chaudhary, who is a senior consultant and endocrinologist in NL Medicare, Guwahati. She is a former professor and head Department of Endocrinology, Guwahati Medical College and Hospital, has been a past vice president of ESI. She has multiple national and international publications and has been a speaker at several state, national, and international conferences, has contributed to chapters in API textbook of medicine and RSSDI textbook, authored book on diabetes in Assamese, which would be so valuable for people in a local language, recipient of the RSSDI Award in Excellence in Diabetes Care. So I hand over the mic to both the chairpersons, Professor Das and Professor Chaudhary, to conduct the session.
Preeti, it's a great pleasure and honor to meet you after so many years.
Yes,
after we worked together in Karolinska, it is my great pleasure and honor to meet you here. And but I've been always inquiring about you and in touch with all that you are doing, good work you're doing. Dear friends, at the outset, sincere thanks. You know, I had a board in my as a director JIPMER and also as a PIMS director. I just had a board saying the best man for any job is a woman. And today the We Care has proven it. And before I start, I'll request Sarojini Madam, my very close dear friend, to say one or two sentences. Then I'll take over for the first two talks. Then Madam will take over the last two talks, but will be there throughout. Sarojini Madam.
Yes, thank you. Really, it's a great pleasure to be here with you all today. And Dr. Das, I am feeling really good to see you after a long time. And all the young ladies, who is very dynamic, very talented. Really is, I mean, I'm really pleased to be here with you to share this session. Actually, diabetes in women is a very important problem because many a time, and women, they never express actually properly what to do, what not to do, and they are hesitant to sometimes. So ultimately what happens, complication starts before they come to consult. But nowadays, of course, they are a little bit aware of the problem. And moreover, it is seen that coronary artery disease or sexual dysfunction, these are more common in women than in men. And today's topics are very much well selected, and we will have good discussion. Naturally, we will have good discussion, and then there will be some question, I think, after each speaker, and then we will have more discussion, and we'll know what are the problems going on. So I think we should invite the speakers.
Yes, yes. Thank you, ma'am. Thank you very much. The madam has introduced the topic. It's my great pleasure to first invite Dr. Archana Juneja, DM and DNB Endo, and fellowship in endocrinology in Australia. She is now the consultant endocrinologist at the Kokilaben Dhirubhai Ambani Hospital in Mumbai. Several publications, A.V. Gandhi Award, National Award winner, R.M. Patel Award winner, and along with her we have Dr. Pratibha Paval. Pratibha Paval is the MD in pediatrics, DM in endocrinology, and she is the consultant endocrinologist at the Spandan Super Specialty Hospital at Aurangabad. She also consultant endocrinologist at the MGM Medical College, Aurangabad. Ma'am, I'm very happy to meet you. I used to go to that college very often, worked as assistant professor, Department of Endocrinology, Nair Hospital, Mumbai before, and joint organizing secretary of the ISBMR and A.V. Gandhi Award winner also. Dear friends, we have 4 parts of the body: the physical, the vital, mental, and above it is psychological, the psyche. And today we are here to listen to a dialogue between these two very erudite, very famous, and clinically, practically updated endocrinologists. A dialogue on the psychological challenges in women with diabetes. Sarojini Madam has spoken about 1 or 2, but the detailed discussion will be by these 2 very erudite endocrinologists. Over to Archana and Pratibha.
Thank you, sir. Very good morning on this Sunday, when we have actually it's a nice conference organized by the Shaila Madam and the team, discussing about the especially the endocrine problems in women. And I know that the topic given to us is psychological challenges in women with diabetes. And I think we have studied, we have a data, huge data from the studies like UKPDS, VADT, and DCCT trial. All these data or all the studies have studied about what should be the HbA1c, what should be the glycemic control, what is the metabolic memory. But I think in these days, we have never discussed about the psychological challenges. And over a period of years, we now realize that the psychological health is equally important for good outcome and delaying the long-term complications of diabetes. So more than 371 million people have diabetes. More than 65 million are in India. And out of this, more than 50% are women. And as per the WHO, the 9th leading cause of death in women is diabetes. And being a diabetes is a chronic disorder, it has got a significant psychological impact on the patient's life in terms of depression, anxiety, poor eating behavior, and more common like diabetes distress. And majority of the guidelines, like we discussed, that it discusses only about the glycemic control, but the psychological aspects are not like equally addressed. And there is marked gender discrimination, which happens in the South Asian country all over the world, but especially in the South Asian countries. And so let us discuss about the psychological challenges in terms of case capsule. So we'll be discussing 2 cases. So she's Meena, 25-year-old female, type 1 diabetic since her childhood. She's divorcee, staying with the 3-year-old daughter. She works on daily wages. And now she presented with the complaints of like low mood, insomnia in early hours as well as late hours of the night, late hours of night and early in the morning. She has got multiple somatic complaints. Since beginning, she is on twice daily insulin. She is very irregular with her medication. That's why she required multiple hospitalization for the diabetic acute complications. On examination, she is a thin-built lady with poor glycemic control, and she also has, that is at the age of 25, she has got both the complications like retinopathy as well as nephropathy. So I would just like to ask Archana Madam how we can help this lady and help her to come out of her problems.
Thank you, Pratibha. At the outset, I'd like to thank Dr. Datta ma'am and Dr. Das sir for your kind words of introduction. And it's indeed a privilege and an honor to be talking this under your aegis. And of course, a huge shout out to Dr. Sheila, Dr. Beena, Gagan, everybody in the team. I think it's been an amazing program lined up. So coming to the point, this patient is going to take half an hour in your OPD, right or wrong? Yes. And how many of us are going to jump at the thought, oh my God, type 1 diabetic and half an hour? But, it's such a sad story that if you had to analyze this, the first aspect is going to be the physical health, the diabetes related issues, sorting out her blood sugars, sorting out her diabetes related complications in terms of a nephropathy, retinopathy, neuropathy. That I think we all are well versed in and we'll all do a good job there. But how many of us actually are going to look into the second and the third aspects of it? The second aspect, which she's come to us basically with fatigue. Now, quite a few of our clinicians are going to brandish this fatigue as B12 deficiency, vitamin D deficiency, are going to adjust her insulin and leave her at that. Though very well at the back of our mind, we know that that's not what is causing the fatigue. There are a lot of emotional upheavals which she's going through. She may be just distressed. She's just helpless. She's overwhelmed by her diabetes. She doesn't know whom to approach. She's a daily wage earner. Probably she has financial concerns. I mean, she may not be able to afford her insulin. So leave alone the glucometer strips and the monitoring, even basic insulin, because she's landing up with repeated episodes of DKA as well as hypoglycemia. The nighttime insomnia, the low mood could all be a part of a psychological health, which we need to be addressing definitely there. And the last is going to be the socio-cultural changes, the environment in which she's living. She's a single lady, has to take care of a 3-year-old child. Probably she's carrying that child with her to the site where she is working. She has financial issues, literacy, awareness is an issue with her. Maybe most important, food is an issue with her. So all these aspects which will need to be dealt with in that half an hour of a consultation, which is going to be a huge burden. We will talk about that. Can I have the next slide, Pratibha? So this was a very interesting sort of a short write-up about the psychological impact of living with diabetes, women's day-to-day experiences. And we have data around the world which says that about 30 to 40% of our diabetic patients and experience anxiety at any point of time in their lifetime. Now, it's more in women as compared to men. Now, similarly, proper depression is seen in 20 to 25% of people with diabetes. And we all know, and it is a well-established entity, that depression is an independent risk factor for cardiovascular disease. It's twice as high in women as compared to men. There could be multiple reasons for this. So anxiety, depression are true psychological parameters which are seen in women, more in women as compared to men. There could be multiple reasons for this. Could be the overwhelming nature of dealing with diabetes, the complex regimens, the need for monitoring, the injections, the pricks for checking, the financial issues, living with the family. I mean, we don't know whether they don't know whether they're going to get adequate support from their family, especially if they are married. If they are not married, whether they're going to find a match for their life, a spouse, a life partner. So most of these diabetes self-management programs, as Dr. Pratibha has rightly said, that we all tend to address the HbA1c, the creatinine, the microalbumin, but most of them do not target the emotional issues of diabetes. This is an increasingly recognized parameter and is now being touted as need to be integrated in diabetes care. Next slide. Yeah. The psychosocial impact of diabetes and comorbid depression. Yeah, before I start with depression per se, there is an entity called as diabetes distress, which is a newly recently coined entity, not new, but this is not depression. I mean, as per, most clinicians would look at, somebody comes to you with low mood, not feeling good, just don't feel like doing anything. It's depression and they're put on antidepressant medications. Studies have now shown that most of them do not have actually depression. In fact, they are dealing with a fear, a scare of how are they going to handle their blood sugars, how are they going to keep it under control? Most of them are aware of the blood glucose levels, which they need to be maintaining. But when they don't get to it, they start getting worried about it. The need for medications, the scare of insulin, the need for monitoring, the lack of support systems, or the fear that they may not get support from their family and their relatives, and of course, access to medical care. So this is called as diabetes distress, and this is more common. In fact, it's said to be about 60 to 70% of diabetics experience not depression, but it is diabetes distress, which could be sorted by just simply understanding and diagnosing this condition and just not putting them on antidepressant medication. 20 to 30% of them will have true depression, and a small minority will have a combination of those two. So it's important for us clinicians to recognize this entity of diabetes distress and not put them on medications right away. So depression per se, it varies depending upon the type of diabetes, developed and developing. And here also I talked about the urban and the rural divide. There are different factors. In fact, we talk about weight loss in other challenges in the rural women. Urban women undergo this process of body shaming, obesity, the need to maintain their thin figures at the cost of high blood sugars. So it's a completely different ball game there. Predisposing factors for depression could include increasing age, female gender, as I said, low level of education. We're not aware. Literacy is pathetic in our country. I mean, it's getting better, but it's still to penetrate at the grassroots level. The taboos associated with Western medicines, allopathic medications, and the relative comfort of safety which are given to them by proprietary medicines and all. I'm not going to talk in detail about that. And the lack of, because of these constraints, they do not seek treatment and care in time. Finances definitely impact. Social circumstances, being single or married, of course, makes a difference, and underlying roles which they play. So eventually what happens for diabetics with depression, they have a poor self-care, poor body image, but to land up with poor metabolic control, increased risk of complications, lower quality of life, and eventually a higher increased risk of death. Next slide, please. So Pratibha, I talked about all these things which data is available. Now, would you talk about something about the data available in the South Asian or the Indian context? Is there anything we have?
Yes, madam. This is a very good data. The study consensus statement done by the women endocrinologists from the South Asia, published in 2013. And this study data discusses about what are the psychological challenges in women with diabetes and at different phases of life. Basically, it discusses about the 5 A's in diabetic women. That is awareness about the diabetes, because of, just we discussed that, like, because of the poor literacy, they are not aware of the diabetes control, what they should do about the good glycemic control and delaying the complications. They have a difficulties in access to basic health care, and that is because, like we discussed, it is poor illiteracy. They are not employed, they are not financially stable, and they have to dependent on the male members of the family to visit the hospital as well as medication. And in some cultures, the women are not allowed to go alone to the clinics, and they have to wait till the time male members finds time to get them to the hospital. The acceptance by the society, like we discussed, if the girl child is having type 1 diabetes, the parents are not worried about the child's health, but they are worried about the marriage and future pregnancy, because that constitutes our future life. Again, the affordability is a factor, and the absence of the trained healthcare personnel about the, not for the glycemic control, but for the psychological issues, to diagnose it early and treat it early. And I think many healthcare professionals are not trained in this aspect of diabetes management. So this study consensus statement discusses about the psychological challenges at different phases of life. Like we have, if a child with the adolescent child with type 1 diabetes, they have a different problems compared to the menopausal females. So once the child is diagnosed with diabetes, specifically girl child is diagnosed, then they are discriminated from the society. It's like a social stigma. And that's why once we tell them that this is a type 1 diabetes and child needs to be on insulin injections, different defense mechanisms are there seen, denial, guilt, they cry, not only the parents and child, both of them are there. So, and we know that in South Asian countries, there is gender discrimination, which starts from the childhood. The good food is given to the male member of the family, and the girl child gets a poor nutrition. And similarly, if there are financial aspects, the male child is given preference for the education compared to the girl child. And that's why there is poor literacy in the women in India. And once we know that the type 1 diabetes is usually diagnosed at toddlers age group and adolescent age group. And if we know that type 1 diabetes is diagnosed at adolescent age group, there are different psychological disorders seen in this adolescent. Girls with type 1 diabetes are more common than the adolescent boys. Like there is higher rate of depression and anxiety in girls with type 1 diabetes. Also, the eating disorders like anorexia nervosa and bulimia are more common in girls. And we know that just discussed that type 1 diabetes will have a marriage issues, and it will start not at the age of 20 or 21 years. But if I say that a 5-year-old child is diagnosed with type 1 diabetes, the parents will start thinking about the marriage and not about her education, her independence, how we can make her literate and self-sufficient. If they try to get married, the proposals will turn away because they have a misconception, myths about their reproductive health, their sexual health, and their cost of therapy that the male member has to bear. And that's why there is turn away of the proposal for the marriage. And even if they get married, after marriage, if their health is not well maintained, there are more chances that she may be divorced or left alone in the society.
Pertinent issues and very, I mean, whatever you said is so real in our country, maybe in our continent.
Yes, madam. And the problems of the childbearing age group, like gestational diabetes, like type 1 diabetes patient getting pregnant or gestational diabetes, the prevalence is varied in various parts of India. And the complications of a diabetic woman in Indian or South Asian countries are more than the other. And that is because there is a poor health of both poor glycemic control during pregnancy. We have a higher complication rates, both in mother as well as the fetus. And that is because of the lack of preconception care. And the meta-analysis of the previous data have shown that those who have got a good preconception care has got a significantly lesser rate of complications, even the congenital malformation, than those who do not receive preconception care. And we know that the diabetes and pregnancy is like a big challenge for a woman, and it causes the progression of both nephropathy and retinopathy during pregnancy if not taken care of well. So apart from this, this is the data from the Psychological University Ireland, which discussed about the outcomes in diabetes in pregnancy, and they have studied what are the psychological problems occurring if the type 1 diabetes woman gets pregnant, is gestational diabetes, and compared to the non-diabetic women. And they have seen that the depression as well as anxiety is significant in case of if the woman having diabetes during pregnancy, because apart from the usual stress of pregnancy, pregnancy is a stressful situation for a woman. And apart from the pregnancy, if they do have a diabetes along with that, and it is newly diagnosed during the pregnancy for the first time, there will be a stress about the diet, the multiple insulin injections, and they have to follow the timings. They are working women sometimes, and they find it very difficult to tackle with all these things. And that gets this woman to fall into depression or anxiety. Once they have studied what is the interesting finding in this study is that those patients who had a type 1 diabetes to begin with, they had a lesser psychological complications during pregnancy compared to the GDM patients who diagnosed first time diabetes during pregnancy, because I think they have got some time to get adjusted with their diet, adjusted with their chronic illness, and they know how to titrate the glucose. The insulin is not new thing for them. So that's why the psychological outcomes or a higher psychological impact was seen in case of gestational diabetic patients who are diagnosed for the first time compared to non-type 1 diabetic. While when we see the adverse medical outcomes, the type 1 diabetic patients had got a more adverse medical outcome of both as well as mother as well as fetus compared to the gestational diabetes, because they have a diabetes many more years before they get pregnant. I think this is a very important data. Apart from this, this is a very interesting study from the African American mothers. This is something like superwoman phenotype, and I think all of us face in this situation, maybe a doctor, maybe a chartered accountant, or any working lady, maybe a primary school teacher. They have to juggle around. Actually, they have to follow the multiple roles as a daughter, as a mother, as a caregiver for the aging parents, as well as in-laws. So she is a role model, and as because of this, she get role overload. There are unrealistic expectations from the family members, and that's why by coping with all these roles, probably she may not be able to give sufficient time for herself. And this superwoman phenotype will cause the psychological distress or diabetes distress. And if she is diabetic herself, and then she has to perform all these roles. I think
Pratibha, this is such an eye-opener. How many of us, actually in this audience have fallen prey to the superwoman syndrome. And you know how much we put that unrealistic expectations on ourselves. I mean, this we're talking as medical professionals. I mean, imagine the lay people. So I think we all women are superwomen, and we should just leave it at that, and don't get bogged down by the roles which which others put on the women to play, that you have to play all these roles. So sorry, anyway, coming back to the next case. So we'll discuss the second case, which is a 48-year-old lady. She's a bank employee, a working woman in the metro city. She's been a diabetic for about 15 years, comes with his symptoms of, again, irritability, feeling of guilt, fatigue, low libido, hot flashes, crying episodes. She's going through her menopausal symptoms. The next slide, the next.
Yes.
Yeah. So she is through the menopause transition, and she sort of put on weight in this time frame. Pandemic has struck. She's put on weight. The blood pressure is okay. BMI is a little on the. She's on the obese side. She's on oral anti-diabetic drugs and basal insulin at night. Yet her A1C is 9.2. She has retinopathy and she has peripheral neuropathy, though the albumin excretion ratio is normal. And she's had an angio done in the past, which showed minor CVD requiring only medical management. So, Pratibha, how would you analyze this case, and what would the salient points on this one?
Yes. So this is again the problems at the elderly age group is different compared to the childhood diabetes and pregnant diabetes. And this is again the sexual dysfunction is another aspect of a woman with diabetes, which is less discussed. And compare like the psychological aspects. And we know that the poor psychological health will impact the sexual function negatively, and which has got a significant impact on her personal life, interpersonal relationships. And the most of the women report that the doctors rarely discuss about their sexual health. And we are going to have a separate topic in this conference. I would like to congratulate Madam to discuss about these issues, which are commonly not seen and managed in our day-to-day practice. So this is definitely going to help us. The healthcare professional may not be fully trained or sensitized for this, and that's why they do not discuss in their busy OPDs, overcrowded OPDs. And also there is social stigma about this, and that's why the female patient do not come up unless you give them privacy and give them sufficient time. Then only they will open up and discuss about these issues. So, and there is minimal work has been carried out in the Diabetic Society, and I would like to advocate all of us that we should come up with the guidelines for the counseling for the female sexual dysfunction, which are written in the culturally appropriate manner in the South Asia, so that this will take care of this aspect of the diabetes. So this is again another study which discussed about the health related quality of life in diabetic women. And this study has come up with the conclusion that the age factor, education, also we know that literacy, duration of the disease, as well as the family income, that is financial aspects, significantly associated with the all areas of the qualities of life. This is again another data from the Asian Journal of Psychiatry about the psychological health and menopause specific quality of life. We know that the menopause is again a second stressful situation for a woman. And if apart from the menopause, she is having again diabetes, then this is a dual problem that she has to face. Anxiety and depression are anyway common in menopausal age group. And this become much more significant if the women have a diabetes and the stress about the diabetes control. And diabetic women will have a more depressive as well as anxiety symptoms compared to the non-diabetic females going through the menopause. So women without diabetes have a significantly higher score for the sexual domain compared to the non-diabetic women will have a higher sexual score compared to the women with diabetes. So again, diabetes has got a significant impact on this aspects of the women's phase of life. So I think these are the issues which are faced at the other end of the
life. We like to close here and go to the discussion because I've been asked to get a little bit mindful about the time. But I must tell you, the amount of data that Pratibha you have presented and the out of data Archana you have discussed is monumental. So can we invite one or maximum 2 comments and questions? Do we have anything in the chat box? I can see two comments in the chat box. I'll just open it. And the Bina wants to learn about one sentence more about the superwoman prototype. Archana would like to speak about the superwoman prototype.
Yes, sir. So this is what I think the multiple roles which are placed on a woman It's not to her. It's not to her wish. I mean, she's just supposed to go on through these roles, and in that time frame of 24 hours, where she has to look at her work, her home, caring for her in-laws, looking after the other aspects of home running, and her own health, that gets absolutely relegated down to the bottom of the ladder. That does impact on her eating habits. So, generally women would eat the last, eat
Yes.
all the remaining food,
Yes.
without paying attention to the nutrient value of it. Exercises out of the window. So all these do impact so placing that tag of a superwoman, I think, is principally wrong, because you put more pressure on the woman to perform multiple roles and not pay attention to her primary health, to her health primarily.
Thank you. And I think great answer. I think the last one will be what Dr. Pratibha has put, the solutions. I think that is going to be great. Can you, Pratibha, take up 2 or 3 main points on the solutions, and we'll end with that, go to the next talk?
Yes, sir. So at the solutions, we need to do at society as well as the health professional level. So more awareness about the health professional about this psychological challenges. And at the society level, we need to get us awareness about the various like media, posters, seminars, which are very commonly used by the population, like the TV seminars, newspapers, and Facebooks and other programs. We can make more awareness. And I think most important is to increase the literacy rate in the women. That will make them self-sufficient and take care of themselves properly. I think
Thank you. I think we had a wonderful discussion. I will just borrow the words of one of our great colleagues, Usha. Usha wrote some time back an article which I borrowed with her permission and wrote a book on that. The diabetes in women is different. It is difficult, distressful, and sometimes can be deadly. And thank you very much, Dr. Pratibha and Dr. Archana, for the wonderful discussion. Big hand for you, both of you. I'm sorry that we have to finish by 10:20. That's the order from the boss. So we have to finish in time. That's why I had to intervene. So now it's my great pleasure and honor to invite the second speaker. Thank you very much, and really appreciate big round of applause for Dr. Archana and Dr. Pratibha. A great job. I think you should write it up. Sarita has written the article, but I think all this, you should make a compendium on the psychological aspects. That will be great help for everybody who comes to the arena. Thank you very, very much.
Thank you, sir.
Can I pass to the next speaker? Then I'll hand it over the session to Dr. Sarojini, madam. Can I have the next speakers? I know Om well. The next talk is a case-based discussion. And to do this honor to us, we have a very, very young endocrinologist from Ahmedabad, a very close friend of mine, MD DNV Endo, Dr. Om Lakhani. She is the President's NB Gold Medal winner in endocrinology, national winner of the ESI TAISA program in 2016, a Big Gandhi Award. She was quite up in the list, and he has got the Bital Rao Nadagoda Award for the best thesis in MD. And one of the most important aspects that Om has worked with is the developer of the Notes in Endocrinology app. I have seen that app. I'm delighted that Om, so much good work we have done. Over to you, because time is short. So many things to speak about it, but let us start discussing regarding the case-based discussion that we are going to do regarding the diabetes with the quiz program. Over to Om.
Thank you so much, sir, for the very kind introduction. It's always my pleasure to share the stage with you. I think it's indeed an honor. And thank you to the team of Women Endocrine Care. I think, it's a wonderful conference, and I think, a great initiative. And I, really, really hope that, we have more of such beautiful events, and stellar organization, I would say, wonderful. So without wasting much time, I understand that we are running a little short of time, so I'll go straight to the quiz, and I'll explain the rules. And this quiz is open to all the listeners, please participate wholeheartedly. So what we're going to do is we're going to discuss about complications in women with diabetes, and we're going to discuss a case-based quiz. And these are the instructions. These instructions remain the same for all the quizzes that have been part of this conference. And I actually thank Dr. Mohan for writing this down, and I'm borrowing his slide. So to everybody who is listening to this, you have a ask a question box from wherever you're logged into. So you need to give your answer here. Not ask a question, you need to give your answers in ask a question box. Of course, you are free to ask questions also, which is of course, absolutely you're right. But this is a quiz and you need to answer it. You need to submit your answers in one single go in a chronological order. We are going to have 5 questions, just 5 of them. And you just need to answer them. It's a multiple choice question. So, you need to say question 1, answer A, question 2, answer A, so on and so forth. Initially I'll present the questions, then I'll give you some time, a few seconds to, submit your answers. And then, at the end of the day, will be the technical team will be calculating the scores. We already provided them the correct answer key, and the decision of the finals, of course, the organizers, and in case of any issues, the quiz masters is fine. So if you're ready with this quiz, let's begin with asking the questions first, and then we'll pause for a few seconds, then we'll discuss the answers and the explanations. Okay, so let's go to the questions. So let's look at the first questions. So, keep your keyboards ready. So this is a 52-year-old female. She's known case of type 2 diabetes since the last 5 years, and she's on your regular follow-up. Now, she attained menopause at the age of 44 years. The patient had a history of preeclampsia in her last pregnancy, which was 16 years ago. The patient is hypertensive, and she's not on any other hormone replacement or menopause hormonal therapy at present. Now, which of the following is true? Please listen to the question carefully. Which of the following is true about hypertension in postmenopausal women with diabetes? So these are your options. A, does a prior history of preeclampsia during pregnancy has no impact on future cardiovascular risk in women? Is this true? Is it true that postmenopausal women have non-dipping of nighttime blood pressure more than men, leading to late night or early morning CVD events? Is it true that fibromuscular dysplasia must be ruled out in all postmenopausal women with hypertension? Or is it true that there are reduction in renin-angiotensin receptors post-menopause, and hence ACE inhibitors, ARBs are not the best agents to use in post-menopausal women as antihypertensive therapy? Okay, so this is the question. I'll pause for a few seconds for allowing you to answer. I'll just repeat. Don't submit all your answers right now. Just write it down, and then at one go, you need to submit all your answers. Write question number 1 and the relevant option which you have chosen, A, B, C, or D. Of course, we'll be discussing each of these points after the questions are over. So we'll give you the answers to this. Okay, let's move on to question number 2. So this is Mrs. X, who is 35 years old, and she has history of PCOS. She also had history of gestational diabetes mellitus in her last pregnancy, which was 10 years now. Now, she has a very strong family history of type 2 diabetes, and she's having a BMI of 33. In March 2021, she was admitted with COVID-19, and she was given glucocorticoids and developed hyperglycemia during this period. And the patient was discharged on oral antidiabetics, but the patient unfortunately did not comply with the medications at that point. Now, the patient comes back in November 2021 with frank type 2 diabetes and HbA1c of 10%. Which of the following is true with regards to type 2 diabetes incidence and future cardiovascular risk in young premenopausal women with diabetes? So you are talking about a 35-year-old woman with diabetes. So is it true? So again, the point is, which of the following is true? Is it true that gestational diabetes impacts the future risk of type 2 diabetes in women, but has no impact on future cardiovascular risk in women? Is it true that type 2 diabetes is more common in men at all ages, including pubertal age, middle age, or older age? So is this a correct assessment? Is it true that women with type 2 diabetes have more risk of heart failure incidence and mortality compared to men? Or is it true that premenopausal women with type 2 diabetes have cardiovascular protection because of good levels of estrogen, and hence, despite having diabetes, they have low risk of cardiovascular disease? Right? So which of the following answers is true? I know it's a little, sometimes I would say complex thing to think about. You might have to think a few seconds about this answer, but the idea is, it's, the most important is not the answer. Most important is the learning points from this, which we'll of course, discuss.
Om, there is a request from the organizers and the audience to go a little slow with the disclosure. Fantastic wealth of knowledge you have brought. So Dr. Beena and others requested me to kindly tell you that to go a little slow, because wealth of knowledge in these 4 choices. So go a little slower.
Sure, I'll keep that in. So
Maybe you can
just to
go.
read,
Yes,
yes.
yes.
So I think, if we'll move on to the next question. I'll come back to the first question again in a few seconds in case, if you have missed out the option there. I apologize for that. Okay, so let's move to question number 3. So, we're talking about the same question here, right? So this is the lady in question 2, which we talked about. This is X. Now, we decided to start the patient on insulin with oral antidiabetics. The patient, remember, was a 35-year-old woman with HbA1c of 10%. Now, which of the following is true with regards to sex difference in terms of therapy selection in women versus men, men versus women, right? So, would you say GLP-1 receptor agonists tend to produce more weight loss in men, but provide better glycemic control in women, right? Is this true? Again, you need to select the most appropriate or the correct answer. Is it true that SGLT2 inhibitors tend to be more effective in cardiovascular protection in men compared to women? Is it true that pioglitazone tends to produce better glycemic control over a long time in obese women with type 2 diabetes compared to sulfonylurea? Again, both traditionally have been very popular anti-diabetic drugs. Or is it true that insulin must be avoided in obese premenopausal women, like this case, with type 2 diabetes in preference to agents like GLP-1 or SGLT2? Right? So you need to, again, I'll pause for a few seconds, allow you to, understand the question, try to go through the answers and select the most appropriate one. So just to remind you, this is a lady who is 35-year-old, HbA1c is 10%. She had COVID in March, and in November, she came with HbA1c of 10% to the hospital. She was, not compliant with her treatment previously. And so these are the options with regards to sex difference in terms of therapy selection in men versus women. Okay, in case you, I'll move on to the next question. In case you miss out something, what I'll do is I'll quickly go through all the questions again. 5 questions, we just have 5 questions again. So I'll quickly go through all the 5 questions again so that you can, if you missed an option or if you missed some critical point, you can kind of, do that, have a look again.
Or we can do the final discussion. You can give the inputs, learning inputs of all
Yes.
the 20 choices that we have. That will
Yes, that will definitely do.
That will save time also. Thank you, Om.
Absolutely. Okay, so let's move on to the 4th question. Again, so these are case-based questions, so they tend to be a little longer. Okay, I apologize for that. Okay, so we have a 56-year-old lady. Now, there is no prior history of myocardial infarction, and she's diagnosed to have type 2 diabetes. Right? She also has dyslipidemia, and her LDL is 190. She's an ex-smoker and does not consume alcohol. These are other risk factors. She is also hypertensive, and her blood pressure is, however, well controlled with antihypertensive medication. Now, she has a very strong family history of ASCVD with her father and an elder brother, not an elder brother, succumbing to myocardial infarction, both before 55 years of age. So, where the things. Now, she's been prescribed statin therapy, looking at her risk factors. However, she refuses to take the same based on something she read online on Twitter. It's a common problem these days. So she brings a list of questions, which is her right, and she wants to discuss this with regards to statin therapy. Now, which of the following is true with regards to statin therapy in women with type 2? That's the whole question, right? So the lady has an issue with statin therapy, and then we want to know what's the right, which of the following is true and which is wrong, right? So first point, is it true that there is no benefit of statin therapy for cardiovascular disease protection in women? Since most of the clinical trials have an overrepresentation of men, the data was then extrapolated to women. Is this true? And this is a very common notion which has been circulated in lay media. And is there any truth to this point? Is it true that statin has no role or has a role for secondary prevention in women, but no role in primary prevention. So with secondary prevention, we mean that the patient who has already had a prior history of ASCVD event. Is it true that for primary prevention of ASCVD, keto diet is more effective than statin? So maybe a dietary approach may be better compared to statin. Is that true? Or is it true that the use of statins in women is associated with higher risk of statin-associated muscle symptoms, right? Like myalgia, myopathy, right? So on. So which of the following is true? Again, I'll allow you to ponder over this point. So the clinical history is that the patient definitely has an indication for statin therapy, looking at her age, looking at her diabetes status, LDL level, which is 190. She's hypertensive also, and she's a very strong family history of ASCVD. So both, had a father who expired at, before 55 because of a cardiovascular event, and then there's elder brother, not an elderly, elder brother who. And we always, I think another underwritten point is that, and I think it's a good idea to discuss these points with your patients, and I'd always encourage my patients to bring this queries they have, something they read online, and, they discuss this with you to kind of clear the doubts rather than to, not deny a therapy or, rather, or accept the therapy without any discussion. So both of which are a problem. So moving on to question number 5. And the last question, and I'll come back to all the questions quickly again, just so that you can, before you submit, you can just go through it. So the last question is about a 36-year-old lady, and she's come to you for a second opinion. So she was recently diagnosed with type 2 diabetes. Right? And on further questioning, it was found that she's having premature ovarian insufficiency, POI. And her last menstrual period was 1 year back. So since a year, she's not had a menses. Since last 3 to 4 years before her menstrual cycle stopped, she had oligomenorrhea. And she did not consult a doctor, unfortunately, at that point in time. She went along with it. Then the periods completely stopped. Her FSH at this point of time, repeated twice, is more than 40, which is clearly in a menopausal range. But then looking at a clinical profile, the patient was, she was also diagnosed with diabetes, as we saw, and she was started on oral antidiabetics. We are not discussing oral antidiabetics here, so, that's not relevant to what was started. But she was also advised to start a new generation menopause hormonal therapy, right? And the patient wants a second opinion because she has again heard mixed reviews of hormone replacement therapy. Again, very strongly encouraging women or patients in general. I think part of, as Dr. Beena ma'am says, humanizing medicine is to, answer these questions which the patient have, or where they read something online, or they want to discuss this. It's very important to answer these questions. So which of the following is false? Now, so far, we had all questions regarding true. But here, we need to tell you, you need to tell me what of the following, which of the following is false, not true. Okay, so is it false that POI or menopause increases the risk of type 2 diabetes? Is it false that menopause hormonal therapy in women with POI reduces the risk of osteoporosis? Is it false that menopause hormonal therapy in women should be given till the age of natural menopause? Is it false that menopause hormonal therapy in women with POI increases the risk of cardiovascular disease in patients? Right? These are concerns of patients. Patients often come and say, "Mujhe heart attack to nahi ho jayega, mujhe stroke to nahi ho jayega." Stroke, a lot of, why stroke is a problem. Right? A lot of women read about this online, because of certain clinical trials which were done in the past. The patients have these concerns, genuine concerns. Would you, which of the following is false? Right? So, since I probably skip through a couple of slides a little faster, I'll just quickly review all the questions again very quickly. Tell you the salient points, and if you missed out something, you can do needful, and then we will then discuss the answers after a few seconds. So the first question was regarding a 52-year-old lady. In case this is especially because I think I moved a little fast here. This is about 52-year-old lady with type 2 diabetes, and we are talking about hypertension, right? And the question was, which of the following is true? So is it true with regard to pre-eclampsia has no impact on future cardiovascular? Is it true that postmenopausal women have non-dipping of nighttime blood pressure? Is it true with regard to fibromuscular dysplasia in postmenopausal women? Or we talked about reduction in renin-angiotensin receptors in postmenopausal. So I think if you missed this question, you can probably go through this again and you can answer it.
I think, Om, in the interest of time, you can give the correct response and
Yes, sir,
discuss all the items. That will be better. You can go to question by question better. Question by
yes,
question.
I have this entire thing. Right now, sir, there are people who are answering these questions online. Just allowing them to, just allowing the technical team to collect the answers for a few seconds. So that, so the question 2 was regard to a lady with PCOS and developing type 2 diabetes post COVID. These are the options. If you missed something, you can go back to it. Okay, third question was regarding insulin with OAD was started in the same lady, and then which was, we are talking about 6 difference in terms of therapy. If you missed a point, quickly you can go through this. Fourth question was with regard to statin therapy in women with type 2 diabetes. I think this question was very clear. I think, issues there. And last was with regard to menopause hormonal therapy in terms of cardiovascular risk reduction in a lady with type 2. Okay, so we are now waiting for you to submit your answers, right? As discussed, you have the Ask the Question panel. You need to submit your answers over there. We'll collate your answers, and then the technical team will come back and tell us who got the most questions correct. In case of any queries, I'll be of course discussing the answers in the next few seconds. So, sir, if you allow, should we discuss the answers quickly?
I think we should discuss quickly because we have taken 25 minutes home, but it is necessary. Wonderful work we have done, but time also important because Sarojini Madam will need at least 40 minutes to 45 minutes for the next 2 talks. So please go ahead quickly.
Yeah. So the first question was regard to this lady with hypertension. We discussed these points, and the important point here is the correct answer is answer B, which is postmenopausal women have non-dipping of nighttime blood pressure, leading to more late night or early morning CVD events. Now we talk about non-dipping is a very important aspect of hypertension management, but it is particularly important in women. I think that is a very important thing we need to understand. Pre-eclampsia definitely has correlation with cardiovascular disease. There is no doubt about it. And women with pre-eclampsia are 2 to 3 times higher risk of hypertension, stroke, CVD, and overall increased mortality. Now, again, women are more likely to develop hypertension post-menopause not because of reduction, but because of increase of renin-angiotensin receptors. And hence, initially, a lot of these women, if you ask them to reduce the salt intake, it is very useful. Then again, very important characteristic is that the non-dipping of nighttime blood pressure. Now, this is generally measured with ambulatory blood pressure monitoring. And this, it's defined as less than 10% reduction of nighttime BP, which is normal physiological phenomena. This is not seen in women with hypertension, postmenopausal women with hypertension. And hence, it's a very important aspect. And hence, this thing. And, there was a trial also done recently where they actually showed that taking an antihypertensive at nighttime, at bedtime, probably reduces more cardiovascular events. This is particularly true in women. And for young hypertensive women, so premenopausal women with hypertension, you need to look at fibromuscular dysplasia, and you need to look at the history of OCPHIL intake. Both of these can lead to hypertension in young women. However, they're not important in older women. Of course, it can happen in older women. Not that I'm saying they're not, but in younger women specifically, they are more important. So I think that's something which you need to come out. And you don't need to screen every older woman for fibromuscular dysplasia, or of course, you can take a history of OCPHIL, no doubt. But then, which is, I think, may not be very relevant. But point here is that, all postmenopausal women need not be screened for fibromuscular dysplasia, but younger women must be. Okay. The second question was with regard to PCOS, a lady with PCOS, and then she developed hypertension after COVID-19. We see a lot of these cases here, and she was then advised, treatment. And what we wanted to know was about the long-term complications of diabetes in these young women who develop diabetes and hypertension. And what it is true, which of the following is true? It's true that women with type 2 diabetes have more risk of heart failure incidence and mortality compared to men. So heart failure is an important long-term complication of type 2 diabetes in women, which is, I think, very important. And I think you should be, again, cognizant of this fact. And again, in terms of therapy, perhaps SGLT2 may be a good option for these women. Again, if you see, the risk correlation between gestational diabetes and future cardiovascular disease, it's very true. Not only does gestational diabetes increase the risk of diabetes, but gestational diabetes also increases the risk of future cardiovascular events also, including ischemic heart disease. In terms of incidence of type 2 diabetes, please note this point. More young girls have type 2 diabetes in their youth compared to men. Young girls have more insulin resistance than boys during the pubertal age. And men tend to have more diabetes in the midlife. And in the older age, the incidence is similar. So peripubertal age, more girls have diabetes. If you talk about middle age, men tend to predominate, and then older age, the incidence is similar. And of course, premenopausal women with diabetes, there is some amount of natural cardio protection offered. But if they develop diabetes, this natural protection goes away. That's the unfortunate part, right? And if you talk about women with type 2 diabetes, do they have more cardiovascular disease compared to men? Yes, this is true. And in fact, in terms of heart failure, it's also more, right? So heart failure is very, very important complication in type 2 diabetes with women with type 2 diabetes. We talk about third question. We are now talking about six difference in terms of therapy use. And the right answer is, I don't think a lot of you would guess, is C actually. So this is like the points are more important than the answer here. What is interesting is that GLP-1 tend to have better glycemic control in men compared to women, but produces more weight loss in women, which is interesting. Pioglitazone, we don't give much importance to it, but gives better glycemic control in women compared to sulfonylurea over a long time. It was seen in a meta-analysis. I given the reference over here. SGLT2, there is no sex difference, but what we saw is that women with type 2 diabetes have more heart failure, so perhaps it was a good choice in women. And of course, use of insulin is dictated by clinical circumstance. So there is no gender or weight issue with regard to insulin. So if the patient needs insulin, patient needs insulin. Doesn't matter whether it's a lady or a gentleman. This is the meta-analysis where they looked at difference in terms of pioglitazone versus sulfonylurea, and they found that pioglitazone or thiazolidinones tended to have a better glycemic control over a long period of time, sustained glycemic control long time. Not that it's the best choice in this patient, but the point is that this is something we should be aware about. The fourth question was with regards to statin use in women, and this is the answer. So women have more risk of statin associated muscle spectrum, which is true. So this is not just a urban myth. This is actually true. But then that doesn't mean that you do not offer statin therapy to these women. This is the point which I want to make. So women on statins have more muscle symptoms. They generally tend to have more muscle symptoms, and the intolerance to statin is more. Intolerance is defined as intolerant to 2 or more statins with failed alternative dosing strategies. Sometimes you can give lower dose and so on. In such women, you can prescribe ezetimibe, which is a good choice. Statins are, is it true that statins are less effective in women compared to men? This is not true. This is an urban myth completely. In fact, if you talk about the CTT, that is the cholesterol trial collaboration series of meta-analysis, they've clearly shown that if you see meta-analysis data, yes, there was overrepresentation of men in most clinical trials, but at the same time, if you see the collaborative data of multiple trials, including 22 statin trials, statins continue to have benefit in women as well as in men. We talk about keto diet. Currently, there is no evidence of any benefit of keto diet in reducing cardiovascular disease. So again, it is not a primary strategy. It's an additional strategy. It is not a primary strategy. That should be kept in mind. Okay. And the fifth question was regard to POI. And the correct answer here was this one. So menopause hormonal therapy in women with POI increases the risk of cardiovascular disease in these women. Right? This is the incorrect option. So we remember the answer here is which of the following is false, and this was the false answer. So in fact, menopause hormonal therapy reduces cardiovascular risk. We'll come to this point. Remember, if you talk about hormonal therapy and cardiovascular risk, there is something called the timing hypothesis. So earlier you start menopause hormonal therapy, the more cardiovascular protection you get, but the later you start, you increase the risk of cardiovascular disease. Remember, there is also something known as early harm hypothesis. That is, women with already having atherosclerosis have a negative impact with menopause hormone therapy. So you need to treat these women before they develop atherosclerosis. And women with POI definitely must be given MHT because the risk of cardiovascular disease is very high. And in fact, POI reduces, menopause hormone therapy reduces the risk of cardiovascular disease in women with POI. And both, of course, estrogen and progesterone preparation may have, the type of preparation also has an impact. That's, of course, for other measures. So I'll just summarize a few important points. Non-dipping of nighttime blood pressure is a common issue in women. It's more common in women compared to men. Heart failure is an important long-term complication in type 2 diabetes with women with type 2 diabetes. We talk about sex difference in therapy. Remember, GLP tends to produce better glycemic control in men, but tends to have more weight loss. Alglitazone perhaps is not a bad choice, but again, it contributes to obesity. But at the same time, we need to be aware of this fact that it's a good choice in women if the need arises. SGLT2 inhibitors, there is no sex difference. Again, clinical trials have clearly proven this. And of course, insulin choice should be dictated by in the earlier talk, we talked about body dysmorphism, and then people refusing certain therapies because of the weight aspect of it, which should not be the case, especially with insulin. And of course, statins are as effective in women as in men for both primary as well as secondary prevention. However, of course, musculoskeletal tend to be more common in women. And hence, you need to be aware of this fact and perhaps, be cognizant of this fact and consider alternative therapies, maybe in terms of ezetimibe or reducing the statin dose and so on. And women with POI definitely must be given MHT because the cardiovascular risk is much higher in these women. And POI, women with POI tend to have higher cardiovascular risk, and MHT definitely reduces the risk of this. So this is our notes in endocrinology app, as Sir rightly said.
Thank you.
And,
I think, Om, thank you very much. I this was a wonderful talk. It took a little extra time, but we are not timekeeping chairpersons. The amount of knowledge you gave and the take-home messages were excellent. I think it is up to the organizers to announce the winner. I have got the winner's name in the chat box. It will be better if the organizers announce the name of the winner she has secured 4 out of 5. Will you announce now, Sheila, Bina, Gagan, or you will announce it later?
So we can announce it now also, not a problem at all. So you can do the honors, sir.
Yeah, I think my hearty congratulations to Shumea Abdul Kalam, who has secured 4 out of 5. A big round of applause for her. Fantastic, Shumea. Can you make your video on if you can? If not, in the interest of time, I'll be very. I'm doing an injustice to Dr. Sarojini, my elder sister, if I do not stop here. But Shumea, heartiest congratulations. And Om, I have heard you nth number of time. Today you were better. Not only better, you were the best among your presentations, and I'm comparing you with you only because and you have done extremely well. And why are you so partial to we care? You should do such things in Men Endocrine Forum also. Am I correct, Sheila? It's a wonderful time. Everything has been spoken so well that I will not reinvent the wheel, but wonderfully well done. And it's a great knowledge that distributed. Over to Dr. Sarojini, Madam, to take to the next 2 talks. I thank profusely both the speakers and the organizers for having invited me. I'll be there, and at the end we'll join. But for interest of time, Sheila, we are beyond time. Sunday belongs to us. Over to Professor.
Fair enough, sir. Absolutely fair enough. So if I'm allowed to use these words, Om is an absolute sweetheart.
Yeah, absolutely.
Thank you so much.
Om, great, Om, great. Yes, over to Sarojini, Madam.
Ma'am, you're mute. You have to unmute the.
Can you hear? Hello?
Yes, ma'am.
Am I audible?
Yes, ma'am.
Yes.
Okay.
You're visible also. Good.
Thank you, Dr. Das. Really, you have entertained us with very nice remarks. And actually, who is it's really very interesting, and I also enjoy very much.
And
Now
I
we
request Sheila and Gagan, all the organizers, to give little extra time at the end, because will not be or to any speaker. Bharti and Rajeshwari must have their full time. So please give little extra time, Sheila, if possible.
Fine, sir. Not an issue.
She has said no problem. Madam, please continue. Madam, please continue.
Okay, next session, Dr. Bharti. She is MD Gynae, consultant, Bharti Hospital, Karnal. She has done fellowship in clinical sexology, and she has obtained FICOG, FRSSDI. She is a president of Karnataka Obstetric and Gynae Society, and she has published over 80 PubMed indexed publications. She is also invited speaker at national and international conference. Yes, Dr. Bharti, please carry on.
Good morning, dear friends. It's a great opportunity to be part of this forum. And I will like to present my views on women's health. So what is important to women, that we will go through it in just this short time. So that will be overview about, my slides are visible, I hope. That's okay.
Yes, yes.
Slides are visible. Good
Yes,
morning.
yes.
So I will be discussing about, because the female sexual dysfunction, I am interested in that topic, and I take care of that part, or women's health, especially those who are suffering with diabetes. So what is sexual health? This is the complex biopsychosocial process. Depending upon the various causes it presents. So it can be because of biological causes, like with the CVS, CNS, endocrine, medication, or sexually transmitted diseases that may affect the sexual health, or because of social reasons, maybe history of sexual abuse, relationship problems with the partner, or psychological stress, and any psychiatric disorder, or any history of past trauma. But today we are focusing mainly on women with diabetes, maybe type 1 or type 2 diabetes, how they are affected, their sexual life is affected because of diabetes. So as per the prevalence studies conducted, the overall prevalence in type 2 diabetes is 53%. Of these, the premenopausal women were less affected, that was around 40%. And in postmenopausal age group, sexual dysfunction was more common. So it is dependent upon age, metabolic syndrome, and atherogenic dyslipidemia. These are strongly associated as a causative agent for the sexual dysfunction. And in type 1 diabetes women, it is around 36%. It may be because of younger age, and at that level, the hormone levels are well maintained, so they are less affected. And they are less affected with the metabolic syndrome and atherogenic dyslipidemia also. So just quickly going through, what is the DSM classification for sexual dysfunction? For women, it is if it is the sexual interest or arousal disorder, or it can be orgasmic disorder, or specifically for women, that it may be the genitopelvic or penetration disorder. So in women with diabetes, the commonest one is the desire and arousal disorder. That is roughly seen in the 70% of women, and the diminished clitoral sensation in roughly 60%, and orgasmic dysfunction is seen, approximately 50% of women are suffering with the orgasmic dysfunction. And common associations are vaginal discomfort, dyspareunia, or vaginal dryness. So what are the risk factors in diabetes? Most important is the age, type, and duration of diabetes, as seen earlier. The complications of diabetes, comorbidities associated with it, or concomitant medication. It can be related to phase of life. Means, once if a career-oriented woman is there and she has stresses of her personal and professional life, and it can be because of psychosomatic factors also. So these are the risk factors. That is the body image issues. Insulin pump, if they are using, they find it hindrance in their sexual life, or their partner may see insulin pump and come to know that they are having diabetes. So this is just a inferiority complex in them. And increased somatized anxiety symptoms are there, and quality of life is affected with the diabetes. And above all is the interpersonal relationship. So specific to the diabetes, if there are vascular complications, maybe micro or macrovascular complications of these, if they're having neuropathy with the autonomic sensory or motor neuropathy, or peripheral arterial disease or coronary arterial disease, all these vascular complications lead to reduced vaginal lubrication, decreased libido, and lack of orgasm. And if there are comorbid conditions along with diabetes, that may be obesity, PCOS, hypertension, dyslipidemia, and recurrent urinary tract infections. Sometimes the young newly married women I have seen, those who had recurrent urinary tract infections and they didn't know that they have diabetes. And with that, the vaginal candidiasis or recurrent UTI, they presented and were diagnosed with the diabetes once they had started their sexual activity. Otherwise, they were totally asymptomatic. But after marriage or after sexual activity, they got repeated infections. And if they have thyroid dysfunction or POF, so most important of these is the psychogenic causes. Once a person is diagnosed with diabetes, women usually complain, since I got diabetes, my husband or my partner has stopped loving me, or that I have getting the inferiority complex. It may lead to depression also, and this affects their sex life very poor, but they perform very poorly in their sexual life. So for this, we have to counsel them about their psychogenic component also. So the depression and coping skills with their disease, those who are poorly controlled because of psychogenic factors, they perform very poorly in their sexual life also. And quality of relationship definitely plays a major role. If partner is encouraging, they feel boosted up and they perform better. And that's the repeated vaginal infections like Candida, Trichomonas, and bacterial vaginosis. If we find any of these conditions, if we treat it, so the symptoms will be relieved and performance will be better. So all these conditions lead to pruritus vulva, decreased vaginal lubrication, especially with the candidiasis, vaginal itching, and soreness of the vulva. And usually such patients suffer from the nutritional deficiency of calcium, vitamin D, and there is lack of neurotropic vitamin Bs, which is seen by the supplementation of vitamin B1. If we supplement, their performance, arousal, everything improves. The brand name is the sulbutamine, so that is usually supplemented for increasing their desire and arousal. So as Dr. Om Lakhani has also discussed about the various medications and their effect on the woman's life. So the concomitant medication, if they are on antihypertensive, they are on lipid lowering medications, diuretics, SGLT2 inhibitors, leading to the chemical pruritus, use of antihistaminics. Very commonly we give them for any allergy or sneezing or cough. Antihistaminics are used. They lead to vaginal dryness. And even with the cough or sneezing complaints, the associated complaint of vaginal dryness and dyspareunia may be seen. H2 blockers, these are seen very commonly in the concomitant medications. That also leads to the vaginal dryness and the complaints. And commonly used oral contraceptives, that also may lead to, in such patients, may lead to the sexual dysfunction. So these are the causes. But do we need to suspect in every woman? Do we need to ask all the patients, women with diabetes, that do you have sexual dysfunction? So it may or may not be feasible for us, or it may or may not be for them to answer it correctly. So in those cases, if it is possible, if you have relaxed OPD and you find that patient is provoking you to ask this question, then you must ask it. But especially in the vulnerable group, like those who have unexplained poor glycemic control, those who have depressive symptoms, or present with microvascular complications, in such group we must ask. So this is about the suspecting, and for such patients we should screen and substantiate our diagnosis with our clinical acumen as well as the aids available to us. So of these, the simplest one is the questionnaires, that is the FSFI, Female Sexual Function Index, and Beck's Depression Inventory. Because for women with diabetes, these two questionnaires are very good, and these help us make the diagnosis very easily. Because commonly such women are suffering from the depressive symptoms also. So if we add these two, the results are very good, and it will be very easy for us to diagnose the problem and treat it and improve their glycemic control. So take a history examination and ask about the phases of involvement, etiology related to it, and contributory factors. Contributory factors may be her professional stress. She is getting promotion, or she is getting transfer, or her child is going for any higher studies. So all these, the contributory factors may be there. But if needed, go for the relevant investigations, just like TSH, prolactin. And if she is presenting with the PID or recurrent PID, must get her ultrasound done. So how to sort out this problem? That can be done by identifying the phase and assess her and optimize her psychosocial factors like sudden change in personal and professional life. So counseling plays a major role in such situations. Optimize her glucometabolic control and review and optimize her concomitant medication. Usually seen in SG, just like patient on SGLT2 inhibitors, they have good glycemic control, but they frequently present with chemical irritation, the chemical pruritus vulva. So in those patients, if we stop it for some time and we find the improvement is there, so we can change the medication for them. And specific therapy can be started just like DHEA supplementation and menopausal hormonal therapy. That plays a very good role. And don't forget, we have to supervise the therapy and outcome on the ongoing basis, because the duration of diabetes changes, the phases of life change. So if we keep it in mind and we take the history and the performance on the ongoing basis, the results will be definitely better for her. So how to manage the situation? Above all is the good glycemic control. Teach her about the good genital hygiene, and her psychosocial optimization should be attained. And specific interventions which can be done, the most important is the counseling and therapeutic patient education. Psychotherapy or couple counseling, if needed, the partner should be involved and should be counseled for psychosocial as well as the physical counseling. Sometimes the partners improve genital hygiene or the partner's blood glucose levels play a major role. And many a times the partner is diagnosed with diabetes if we ask the history in detail, because if after every sexual contact she is getting repeated in vaginal infections, so must check her partner's semen analysis as well as his blood glucose levels. And drug therapy has a definitive role, but the first and foremost is the psychological therapy as well as the medical therapy for that. So what is the therapeutic patient education for such patients? This has a theranostic approach. If we tell them the anatomy, physiology, and role of good glycemic control, and role of good nutrition and nerve health. So for these, we will give them medication. But if it, just like in OHA, they are not getting their good glycemic control, we can motivate them for a short-term insulin use to improve their sexual health. Most of the times that thing works very well. So if they get their good blood glucose control and their sexual life improves, they are willing to continue insulin for a longer time for their good health. And that will help in improvement in their general health also. So for genital hygiene, explain in detail the choice of clothing, choice of sanitary products, cleansers and soaps. Commonly we see just like the V-wash and that the genital, the ladies use the V-wash because they see the ads in their TV or otherwise they ask their friends. So if they have pruritus, they start using that hygiene products. And because of those chemicals, they get repeated irritation, means the vicious cycle starts, repeated use of chemicals, repeated use of vulval and vaginal infections. And the main role of menopausal hormonal therapy that can be given locally in the form of estrogen or MST and DHEA. These things help in increased lubrication of vaginal area. And psychosocial optimization, that is a couple-based family counseling, and the buddy system. Sometimes the partner, we have treated the partner, but sometimes the issue is with their mother-in-law or their other family members. So that we have to address, because sometimes they have just a joint family and small rooms, or they don't get privacy. That thing also leads to their sexual dysfunction, but they can't explain, they can't tell it to their family members or their partner also. So if patient takes you in confidence, you just counsel appropriately. And buddy system is very good. Sometimes at the time of marriage, as we see the sister or sister-in-law, they come and help her in their sexual counseling. So we can call their, means the person in which they confide very comfortably, we can take their help and solve this problem. So that means the support, education and counseling play a major role. And for their sexual activity, if we tell them about the relaxation exercises, mindfulness, cognitive behavior therapy, and especially the sunset focus exercises, even if we don't give them any medication, if we tell them all this psychosocial, do the psychosexual therapy very well, the results are better, because these things lead to increased desire as well as the lubrication. And pelvic floor training, desensitization. And if some women get vulvodynia, in those cases, the anesthetic gels and creams are useful. And for medical therapy, the sibutramine that can be given 200 milligram once daily after breakfast, yohimbine in the evening time in the dose of 6 milligram, or sildenafil. For women, the 25 milligram dose is preferable. It can be given vaginally or orally on SOS basis. And for lubrication, the arginine sachet in combination with ginseng, that is also very good if taken once a day in the evening. So performance at night improves. Bupropion in 150 milligram OD can be given. And for lax vaginal outlet, the Botox therapy can be given. And for increased lubrication, oxytocin nasal spray are in research, but they are available in other countries also. So the condition specific to vaginal pain disorder, that can be a part of painful diabetic neuropathy, as we see it in feet, legs, and sometimes in hands also they complain. So in vulval area, sometimes a pain disorder is there. On examination, you don't find anything abnormal, but patient complains of pain, burning sensation all the time. So for those patients, the specific, those who have who are having diabetes, so we can, just to go through it, the provoked vulvodynia can be there, or generalized vulvodynia. Sometimes the women having recurrent fungal infections, they complain of clitoridynia. They get pain in their clitoris. Sometimes the clitoris is swollen and dark pinkish in color, erythematous, edematous, and very tender. So this is otherwise underreported and under-recognized condition, but sometimes the dyspareunia is actually the clitoridynia. So for this local examination, cotton swab test, tampon test, at wet mount culture is to be done. And for this, if we suggest them the GABA mix gel, that is a local application of xylocaine jelly, and the combination is there, that can be used. Estrogen cream and oral medications can be prescribed. So this is very commonly reported in OPD and the generalized complaints, and we don't find anything, but we have to think vulvodynia in mind so that we can treat it well. So in short, the optimum treatment of FSD can be planned as if the one presents with a low libido and motivation or inclination to be sexual. If we take history and we don't find anything positive about it, that may be because of poor glycemic control. Or if she has low libido, but she is highly motivated, she wants to be sexual, but she doesn't get desire when she wants it. So assess for her testosterone levels and prolactin levels. And if she has normal libido, but low motivation, that I get desire, but when the time comes, I just don't want to do it. So then I don't want to do it with the same partner or otherwise. So if she has normal libido, but she is not motivated, that may be because of her psychosocial relationship with her partner or family members. And if she has normal libido and motivation, and she is unable to perform, then must check for her vascular and local factors. So if we take all these points into consideration, that will be very easy for us to diagnose, treat, and manage properly for a long-term basis. So just to summarize, FSD is underdiagnosed, underreported condition. I think I should label it as under-asked, means we don't give time to our patients to discuss about their sexual concerns. So we should give them just 1 minute extra so that they can open up. Or even if they don't open up in their first visit, if you just ask them in second visit, they will definitely ask you that, doctor, you were asking me about my sexual health. At that time, I was a bit hesitant, but now I am telling I have these concerns. Please address my concerns. So this is more common in diabetes affecting her personal and professional life, and address it proactively. It can be treated with therapeutic patient education and medication, and optimizing sexual health improves the quality of life in the form of personal, professional life and medical life. That means if her blood glucose are well controlled by improving the sexual health, so that way she will need less of medication and she will remain happy, and definitely the society will also gain with this. So that is my take home, and thank you for that.
Thank you, Bharati,
Thank you
for
the
elaborate discussion. Thank you, Bharati,
Thank
for
you.
elaborate discussion on sexual dysfunction. It's a quite common problem in diabetic women, and we have to take the message, whatever you have spoken. So because of paucity of time, we'll go to next topic. Dr. Rajeshwari, please.
Good morning, everyone. I first of all congratulate the VCare team for organizing such an excellent program, and also I thank them for giving me this opportunity. Like the previous two topics, like sexual dysfunction, psychological distress of diabetes, contraception in diabetic women is something less often spoken in clinical practice day to day. Hope you can see my slides.
Not yet, Rajeshwari. Not
Can you
yet.
hear me? Can you hear me?
I can hear you, but the slide is not visible.
Rajeshwari's CV is not focused. Veena? Yeah.
Can you see now?
Yes. Yes.
Yeah.
Yes.
Okay. So contraception is in diabetes. We often neglect in our OPD practice. In a busy practice, we are more concerned about controlling the A1C, blood pressure, statins, etc. So we know the diabetes prevalence is increasing, and more importantly in the younger age group, that is the reproductive age group. And women, we are more often, I think in Bangalore at least, I'm seeing more of type 2 diabetes in pregnancy than GDMs in fact. And we know all the complications of unplanned pregnancy in a diabetic patient, both maternal and fetal. And it's an IDF atlas. It's unlike like in any part of the world, number of women in the reproductive age group having hyperglycemia in pregnancy is increasing. But type 2 diabetes, that is pre-diabetes, preconception diabetes, is also increasing, especially detected first time in pregnancy. That's a very sad state. So we have one of the typical cases. I recently saw a 24-year lady, came with irregular cycles and weight gain. She had a strong family history of diabetes and cardiovascular disease. Examination, she was overweight, acanthosis, and normal blood pressure. So, and investigated found newly diagnosed diabetes. Probably the irregular cycles is also because of polycystic ovarian disease. She's a nullipara. So when such a patient, we jump into trying to counsel about diabetes, control, everything. But most important, we forget is about the contraception. Maybe she's married or sexually active, we don't know, but it's important to just, at least when you finish your consult, about her plans of marriage or pregnancy. This we should always ask for. So why is it? Because even in countries like US or in UK, the number of people seeking contraception in a diabetic and a non-diabetic is diabetic women ask for less contraception, and the prescription by the their practitioners is also less. They are more less likely to prescribe contraception, oral contraceptives, especially for diabetic women when compared to non-diabetic users. Similarly, in type 1 and type 2, all of them, when you look at, the prescription of contraception is very less, and it's not only from the physician or healthcare worker. From the patient side, they don't ask for it because they don't know the implications of very high glycemia and conceiving. So because of ignorance, probably. I think so. We should start the dialogue with the patient about contraception because they are aware of the problems. Why is a concern? Why do we prescribe less hormonal contraceptives to our patients with diabetes? I think the concern is about worsening of the glycemic control and the cardiovascular risk associated. So I'll go through and just show what are the implications of that. So we know that, this is showing that higher the A1C at conception, the higher risk of congenital anomalies. So that is the most important reason we should talk about contraception. So when we look at the various contraceptives available for us, the least effective ones are the, barrier methods most of the time. And when I ask my patients, what are they using? In generally I ask about contraception. They use these, less effective methods of contraception if they have diabetes. Even otherwise also, especially so in diabetes, so the chances of these ineffective and accidental pregnancy is higher. What we prefer is something like a reversible type of contraception, like injectable or oral hormonal pills, or patches, vaginal ring, etc. The alternate or more effective will be in fact lactational amenorrhea, but with irregular cycles and all PCOS, it may not be so efficient also. And permanent methods or long-term methods like a sterilization, tubal ligation, or intrauterine devices are also very effective types of contraception, and they are not sort of we have to counsel them until, otherwise most of them use the less effective methods. WHO has some medical eligibility criteria for contraception. Category 1, there is no restriction for any problem with this type of contraception in that particular person. In category 2, the advantages are higher than the theoretical or risks for that method. Category 3, the risks are there, but advantages still overweigh. And category 4, there is unacceptable high risk of adverse events, so that contraception should not be used. This is a category for different contraceptive methods. When we apply that to diabetic patient, so some of the hormonal, mainly these are for hormonal ones, copper intrauterine device, LNG or the levonorgestrel lutein ones, progesterone implants, DMP, dipomedroxyprogesterone acetate, and progesterone only pill and a combined hormonal pill or COC. So in gestational history of gestational diabetes, no current diabetes, then all of them are category 1 and there are no problems. When it is type 2 diabetes without any vascular or any micro or macrovascular complications, all of them, most of them are category 2, where the advantages are much better, more than a unwanted pregnancy. In type 1 also it's a similar. However, when they have micro or macrovascular complications, especially the dipomethyl medroxyprogesterone and combined hormone pill, they are a contraindication or they have higher adverse effects, so we should be avoiding. So diabetes, they don't come with one problem. They have other things like, history of age, higher age group, smoking, multiple risk factors like, hypertension, dyslipidemia, family history. All these may be there in most of our patients. They're not simple plain diabetes. So risk factors may be there, may not be having a complication as such. So when we look at the same, as I said, combined contraceptive pill or dipomedroxy, DMPA, then the risks are higher if they have multiple risk factors, like hypertension, smoking, or blood pressure, systolic or diastolic. So we should be cautious. So when we want to prescribe, diabetes is one criteria. We have to look at other risk factors, 1, 2, for cardiovascular disease. Second, look at the complications of diabetes and then take a decision about what type of contraception for them. So coming to combined hormone contraception, where there is a combination of ethinyl estradiol along with progesterone. The earlier generation of progesterones like medroxyprogesterone, they are higher, more of steroidogenic effect. Then the next generation came like levonorgestrel and all, they had a little bit androgenic effect compared to progesterone alone. The latest ones like desogestrel and all, they have much lesser androgenic effect also. So they are, they don't have much. So what does estrogen do? It doesn't change much of the insulin sensitivity, nor the glucose tolerance or the insulin production. So in type 1 diabetes, there is no problem. Even in type 2 diabetes, estradiol component doesn't cause much problem. Whereas the progesterone component does increase the insulin resistance is because of a slightly serotonergic or androgenic effect. As a result, slight increase in the glucose levels. When you look at OGTT, the area under cover may be higher based on the type of the progesterone, because now ethylene and estradiol, higher doses had problems, but lower doses like what we use at 30, 35 do not cause any change in the glycemic control of these patients. So in uncomplicated diabetes patients, the benefits are much more, even with a combined hormone pill on long term. And if they have a macrovascular, definitely the criteria MEC will be 3/4. So we can try and look for alternative methods of contraception. However, if the patient doesn't have complications of diabetes, but a smoker or a increased risk for thromboembolic or a severe MI, then probably we should avoid this type of contraception. Then coming to progesterone only pills, this usually it is seen, in immediate postpartum where lactation is a question, when, progesterone doesn't interfere with lactation. So we don't use a combined pill in that, especially postpartum period where the risk of thromboembolic phenomenon may be higher. So POP is safe in diabetes with or without complications. It can be used, and it comes under WHO category 2. Lactation, as example, even so the risk of thromboembolic are not higher. Even despite vascular complication, hypertension, it can be used, progesterone only pills. But the only problem is intermittent, unpredictable bleeding is something patients don't like. And it can be used, we have to use in particular timings, you can't miss the doses very much. Then there is this long-acting reversible contraceptions. I've listed out this. Copper T is commonly very used in India, and it can be encouraged in many of these, especially for spacing between two pregnancies. It is commonly used, or in long term also, especially the LNG eluting IUDs. They don't interfere with the glycemic status, and there is no consistent increased risk of either weight gain or metabolic adverse effects with either of these intrauterine devices. Progesterone, as I said, DMPA, some in non-complicated type 1 and type 2 diabetes, shorter periods, it's fine. However, the risk of weight gain is, like many studies have shown, it does have increased weight gain and some metabolic abnormalities, though, and in fact, long term, especially more than 2 years, some effect on the bone mineral density it can affect. But WHO has given a statement that despite the risk of this complicated pregnancies is so high, it's better to use it rather than, because many of these, especially rural and other places, it may not be regular other contraceptives may not be used, and because it's injectable, longer duration of follow-ups, it is more commonly preferred. Where I go to Tumpur, many people use this type of contraception in the remote areas. Of course, subdermal we don't have much of, and vaginal rings similar to IUD, and they don't have much problem. It can be used in postpartum. In fact, within the first week of postpartum also can be used. The risk of ejection of this device is much lesser after 4 weeks, but it can be used even before. So most patients, when you ask for oral contraception, in fact, many healthcare providers itself, they are worried about the weight gain. But most of the studies, the weight gain is very minimal with a combined pill. Progesterone alone pill, sometimes, especially the injectable DMPA, can cause more weight gain because of the steroidogenic effect. But it is very insignificant. So we don't have to worry. It should not be a reason for not giving contraception. I just touched about carbohydrate metabolism with hormonal pills. As I said, less than 35 microgram of ethinylestradiol, no significant effect on the fasting glucose or insulin secretion profile or insulin resistance. nothing, because whatever the estrogen improves, the progesterone slightly negates it, and so it is they come back to the baseline for a normal person, how it would be compared to a non-diabetic person. Insulin levels slightly increase, not very significant for any significant change in the glycemic profile of these patients. And progesterone only pill, very minimal. So next question is patient with diabetes. In fact, these patients who had gestational diabetes would likely to come for follow-up properly compared to those who didn't have gestational diabetes, and also they inquire about contraceptives much more. They know the important, definitely lactation is an issue. Progesterone only pills could be advised, and no risk of thromboembolism. Later, probably after short duration of this, they can shift to a oral contraceptive pill. It should be fine, or any other spacing devices like implants or intrauterine devices. And these are very highly effective. Of course, if they want to complete their family, they can go for permanent methods like tubal sterilization. So what happens, contraception after GDM, there have been long-term studies up to 7-8 years people have done. It's a non-hormonal, the first graph shows non-hormonal how it works. I mean, progesterone only, especially injectable ones, whereas non-hormonal and estrogen combined pill, there's not very much difference in the rate of conversion to diabetes post-GDM. Similarly, a longer time follow-up, if it is progesterone, definitely the risk is higher. Progesterone only, especially the DMPA, injectable one. Whereas with combined pill, definitely it is much lesser. And DMPA, the higher, the longer duration you use, the risks, in fact, odds ratio is about 8 or more. So we can definitely avoid this type of the currently available with progesterones are much safer and are not glycemic, diabetogenic. Looking at the lipid profile, that is one more concern why many people are not prescribed oral hormonal contraceptives. If you look at lipid profile, estrogens have a favorable effect. We all know increase in HDL, a reduction in LDL, and increase in triglyceride may be there. Whereas progesterone is slightly altered. That is, HDL reduces, LDL is reduced, and triglyceride is also reduced. Overall, if you see combined pills, they don't have much of it. Mostly we would say as neutral on the law, but clinically no significant disturbance that we can see. So when we have diabetes patient with vascular risk factors, or they already have a micro or macrovascular complication. So in the what we see is whenever we say contraceptive pill, we are worried about the thromboembolic phenomenon. Mainly we talk about the venous thromboembolism or pulmonary embolism and such, or cortical venous thrombosis. When it comes to diabetes, though these are risk, it is the risk for venous is same as the non-diabetic patients for these complications. But in diabetic patients, one more aspect is the arterial thrombosis risks like stroke, which is higher when compared to non-diabetic patients. Similarly, myocardial infarction is higher in these patients, and especially so in patients who have hypertension and smoking risk. So when we, if the patient has, diabetes, we prescribe a combined pill. Most importantly, on follow-up, you ask for their regular use of it, and also monitor lipid profile, weight, and blood pressure, because these can increase the risk for these the vascular complications. But it is not the vascular complication, except for the stroke and MI, it is not much more compared to the other non-diabetic population. More importantly, it is higher when the age is younger. However, when you look at the complications of diabetes, at least retinopathy is not worsened when they use these contraceptive devices. However, it should be used with caution in patients with nephropathy. Most important, as I said, a non-hormonal contraception most often use barrier method. The failure rates are high. However, the risk of sexually transmitted diseases are lesser with barrier method. So that is one of the advantage. Natural method based on the days of period, that can be very effective and properly used. However, in many of the diabetic patients, we see they have polycystic ovarian disease and unpredictable cycles. So it may not be very practicable. And if you're going for a sterilization or a procedure like insertion of a copper T or a drug-eluting IUDs, then good glycemic control should be ensured to prevent infection or expelling of these devices. And in case of so many patients, if they have high risk for cardiovascular complications, they may want to go for a barrier method if they have not had previous pregnancies. In that case, one more thing that we have to inform this: in case there is a failure, they're being suspected of the barrier method, then emergency contraception is something which is very efficacious. And even if it in a particular time frame that they have to be used, even if they have micro or macrovascular complications of diabetes, it has no contraindication. Also, if they want to go for a copper T device within the 5 days of exposure, then it will be still effective. So the risk benefit ratio, when you look at, the benefit is much more when they use emergency contraception than the risk associated with a unplanned or unintended pregnancies, even despite having vascular complications itself. Of course, preconception, I think someone is going to talk about it. So we have to inform our patients. So this period of contraception that they're using, let them control their sugars and plan out the pregnancies. There should be no unplanned pregnancies if they have diabetes. So I will conclude by saying that diabetic women, diabetes is commonly seen in reproductive age group pre-pregnancy. So they tend to have complications and high risk factors for cardiovascular diseases, and unplanned pregnancies with high glycemia are a high risk for the fetus and the mother. And I made it a policy, like any patient, young woman comes with diabetes, I ask them, one of the final questions will be, are you planning pregnancy or using contraception? Without that, I never send any young woman. And because I have to change the list of medication one, and if they are not planning for pregnancy, we should talk about contraception, at least if not in the next, they should be primed to it. It's very important. So we have to be proactive about this, because they don't know the side effects of a poor glycemia on pregnancy. And combined pill is usually very safe. This we have to disseminate among our healthcare workers, because they themselves don't prescribe it very often. And avoid combined pills in complicated diabetes. This I end this talk, and thank you.
Thank you, Dr. Rajeshwari, for your excellent and informative talk. Actually, contraception is very important in a diabetic woman to plan a safe pregnancy. So sometimes it's very difficult to choose which one to select. Thank you very much for detailed discussion. Now, I think I must congratulate all the speakers for their excellent and detailed discussion. I must congratulate all the organizers also for the topics they have selected. Thank you. I think time is over for this session. Bina?
Yeah, thank you, Dr. Sarojini. Thank you very much. We really stepped beyond the timings, but the sessions were very interesting. If there is any question, I'm asking for that. Mintu, someone from the IT team, are there any questions there? I think we don't. If someone wants to ask questions here, they can. Otherwise, I'll move from contraception to conception now. And the next session is on pregnancy and diabetes. So I'll invite the coordinators for the next session, Dr. Mala and Dr. Usha.
Okay, thank you.
Can we have the slides, please? So we have Dr. Mala Dharmalingam here, who is Professor, Director and Head, MS Ramaya Medical College, and she has many awards, many orations. She doesn't need any introduction. One of the women leaders here amongst us, and I'm sure the next two coordinators will lead the session really amazingly. More than 130 publications. So welcome, Dr. Mala and Dr. Usha Sriram.
Hello.
Yeah, hi, ma'am. She is a graduate of Madras Medical College, American Board Certified in Internal Medicine, Endocrinology, Diabetes, and Metabolism. We know that she has really worked so much in women endocrinology, women and diabetes, and she's founder of Divas, an NGO for prevention and care of diabetes and NCDs in girls and women, president Indian Society of Bone and Mineral Research, IDF Stream for Women and Diabetes Committee, and her areas of special interests are NCDs in women, gestational diabetes, preconception care, bone health and diabetes, and cancer and diabetes. Over to you, Dr. Mala and Dr. Usha.
Thank you, Bina. A very good afternoon to everyone. And it's my pleasure. We are in the penultimate session for today, but a very, very important topic of pregnancy and diabetes, especially in Southeast Asia and India in particular. And it's my pleasure to introduce two of my very good friends, Dr. S.K. Sharma. Can I have his slide, please? So Dr. S.K. Sharma is an endocrinologist who did his DM from PGI Chandigarh, and he's now consultant endocrinologist at Galaxy Specialty Center, Jaipur. He's had a past experience of being a professor of medicine in Mahatma Gandhi Institute of Medical Sciences. He's got a lot of publications in Index Journal. He's chairperson of Diabetes Welfare Society and also the chairman of the DTCon, which is Rajasthan based, and he has been awarded oration of Vijayawada Yella Manch Diabetes on 2012 and many, many orations. And our next chair is Dr. Can we have the next slide, please? Is Dr. Suresh Damodaran, another good friend, and he's done his MRCP from UK and CST also of internal medicine from London, and CCST of diabetes and endocrine also from London. He's a consultant endocrinologist at Sri Ramakrishna Hospital in Coimbatore, and he's an honorary consultant in Derryford Hospital in Plymouth, and he's affiliation vice president of Endocrine Society, executive council member of Endocrine Society of Tamil Nadu, and founder president Diabetes Endocrine Thyroid Society of Coimbatore. He's got lots of awards and honors like the Donald D. Edziviller International Scholar Award from Minnesota and Diabetes Awareness Initiative Award, and he does an excellent conference every year called TICON. Over to the chairpersons, Dr. Sharma and Dr. Suresh.
Good morning, madam. Thank you very much for your very kind words. Regards to you and as well as Madam Usha Sriram. And today we are going to have a very important debate, I should say, which is whether we should use metformin or insulin in eminent speakers here. Dr. Girish Parmar will be speaking for the metformin. As we know, Dr. Girish Parmar is MD, DM endocrinology, consultant endocrinologist at Nanavati Super Specialty Hospital, Mumbai. And he has fellowship in diabetes foot disorders from Manchester Royal Infirmary, UK. And he is faculty for CPS, Diabetology and Public Health Foundation of India sponsored certificate courses, and Economic Times awarded him for as a distinguished endocrinologist of 2019. He authored and co-authored many research papers and published in many peer reviews. So Dr. Girish Parmar, over to you for highlighting what is your preference of metformin in GDM patients.
Well, I hope I'm audible. I hope I'm audible. Good morning, everyone.
You are audible.
Seniors and respected colleagues. Well, at the outset itself, I'd like to thank Team We Endocrine Care for inviting me to talk upon metformin as an acceptable option in GDM. Well, I think true to the spirit of we endocrine care team. The caption is we. And therefore, what I noticed over here is it's a duologue and not a debate. And therefore, I'm happy that both B and Pia, Dr. Pia Balani, would be giving you different perspectives in the management of gestational diabetes. So I'm going to talk for metformin. But let me start by a quote by Noam Chomsky, which says that optimism is a strategy for making a better future, because unless you believe that future can be better, you are unlikely to step up and take the responsibility for making it so. Well, gestational diabetes, we all understand, is an increasing. 1 to 14% of all pregnancies are complicated by gestational diabetes, and it is associated with adverse maternal and neonatal outcomes. Well, the traditional management for gestational diabetes has been initiation of medical nutrition therapy and addition of insulin as and when needed. So insulin has been the cornerstone of management of gestational diabetes since long. However, it's quite effective.
I think there is some problem of internet or so.
Yeah, Dr. Girish, you are not audible in the slide.
I think he has to reconnect.
Yeah. Should we move on to the second part of the conversation, or is it in continuity, Dr. Pia?
Mine is a pro-insulin kind of thing. So it's not in continuity necessarily. I think we could take it in any order. Should we give Girish half a minute and then move on, Dr. Bina? Or
yes, I
know we're running tight on time though, yeah.
That's okay. I think as Dr. Ashok said, it's a Sunday, so yeah.
By that time we can introduce Dr. Pia.
Yes, yes.
Sure.
So Dr. Pia Balani Thakkar is diplomat of American Board of Endocrinology, Diabetes and Metabolism, FACE, MD, Obstetrics and Gynecology from KM, and she is consultant endocrinologist, Bombay Hospital and Medical Research Center, Dr. Balani's clinic and at Kolaba, Bombay. Founder member of and honorary secretary of PCOS Society of India. Several publications and book chapters contributed by her. Best Doctor of Mumbai 2022 by Outlook magazine. America's top physicians by Consumers Research Council of America. Physicians Recognition Award with Commendation AMA. The Sur and Purandre Prize and Purandre Memorial Prize. An area of interested women's health, gynae endocrinology, and diabetes and thyroidology. So with that, I think Dr. Parmar is joining us.
Sir, I think I just spoke to Girish.
Yeah.
Let's have Pia's talk first.
Yeah, you can share your slide.
All right. So in this continuing duologue, as I like the term that Girish put in, because it's not supposed to be a debate, it's points of view with the insulin versus metformin in pregnancy. First of all, thank you, organizers. What a wonderful initiative. Thank you to the chairpersons to give me this opportunity. So I'm going to speak a little bit about being pro-insulin in gestational diabetes and why. Because a successful pregnancy is one where we have a healthy mother and a healthy fetus. Insulin, like we know, is the safest option for the fetus and the neonate. Number two, what we want in GDM is to achieve excellent glycemic control. And as we're all aware, with insulin, it is one of the most celebrated molecules in our pharmacopoeia, with no ceiling, no limit to its extent in its capability of achieving this control. Insulin easy to administer, I don't mean this to be in contention with an orally administered pill, no doubt about that. But today, if I have a choice for a woman who wants to get best outcomes with an agent, that has to be given for a limited period of time. Where does the scare of insulin appear to folks? It is when we tell them this is a lifelong issue. But if we're getting best outcomes with an agent for a limited period of time, a percentage of these women might already have used injections for fertility purposes, for anticoagulant purposes. So there is that kind of commitment to using insulin for that limited period of time, like we all know, is possibly there as well, especially with the newer pens. And finally, the flexibility. Today, whether a woman is eating poorly due to hyperemesis, is eating too much due to hunger pangs, has a betamethasone-induced exacerbation of hyperglycemia. So with all of that, the adaptability of insulin is unparalleled. So let's understand, why do we even treat diabetes in pregnancy? Like we all know, there's an increased risk for LGA babies. There's an increased risk of complications, an increased risk of maternal type 2 diabetes. 50% of women are at 10 to 20 years, and an abnormal glucose metabolism in childhood that stems from the fetal programming that happens right during pregnancy. And it is to prevent these complications that diabetes in pregnancy should be treated meticulously, extremely strictly, to the point that all of the societies, majority of them, like you're seeing, have A1C targets of less than 6%, because we are aware that pregnancy is this period where short-term intensive control is going to have very long-term payoffs in terms of avoiding complications, in terms of avoiding the IGT, the obesity, the type 2 diabetes in the offspring. This is going to be preventive medicine that starts off even prior to birth, preventive medicine at its best. So if we look at this one systematic review and meta-analysis, which evaluated what are the benefits and harms of even treating GDM, where treating GDM results no doubt in less preeclampsia, shoulder dystocia, and macrosomia. But also, is there evidence to show any harm? Well, there's no effect on neonatal hypoglycemia or future poor metabolic outcomes. There is little evidence, therefore, of short-term harm of treating GDM other than an increased demand of services, which no doubt is something that lies with us. So in terms of management, well, with 80 to 85% of women, lifestyle intervention is going to solve and get them back to glycemic goals. But where pharmacological intervention plays a role, our choices are two: insulin, which is the gold standard recommended treatment, the first line recommended treatment, whereas with metformin and glyburide, well, with metformin and glyburide, these are not recommended as first-line agents. Why is that? Because we have to answer the question, is insulin safe in pregnancy? And currently available human insulin preparations do not cross the placenta. Analog insulin preparations also have proven their safety as well. A number of different studies have been done to this end, whether it is for insulin aspart, lispro, detamide, even studies with glargine, and for that matter, degludec, have shown that women who've been on, let's say, glargine and degludec prior to pregnancy with extremely good control, there is no compelling evidence right now to say that they need to move their insulins. Let's talk about metformin. Well, I think Girish would have done that, but is it safe? Well, metformin crosses the placenta. There are higher concentrations in the fetus sometimes as compared to the maternal circulation. So like we're seeing over here, the conclusion over here in this particular study, at the time of delivery, the fetus is exposed to metformin concentrations from negligible to as high as the maternal concentration. This was done in this pharmacokinetics of metformin study. Another meta-analysis that I am going to highlight over here on the right side, I put that down in details over here, which showed amongst 1270 participants, the preterm birth rate was at an odds ratio of 1.74. This was another study, the mixed study, metformin and gestational diabetes trial, which evaluated metformin versus insulin during pregnancy, and more importantly, then a follow-up in the offspring at the 2-year and the 7 to 9 year mark. The mixed study in itself, 750 women, who were either given insulin or metformin with supplemental insulin if needed, Importantly, the pregnancy outcomes were similar between both groups, but women randomized to metformin delivered a mean of 1.7 days earlier with an increased rate of preterm birth of 12.1 versus 7.6%, which was statistically significant. The second important outcome was that, as we all know, metformin very often cannot handle pregnancy start to finish alone. 46% of patients in the MIG trial had to be supplemented with insulin of different kind of natures. We're not going to go into the regimens over there. The 2-year follow-up, this was the MIG tofu study, studying the body composition to see whether the medications were safe for the offspring, what were the long-term outcomes. And over here again, like we're seeing, with the follow-up here, the body fat showed no difference between the two treatment arms. However, the mid-upper arm circumference was larger, biceps and subscapular skin folds were greater in the offspring of women randomized to metformin, showing that there was an increased amount of subcute fat, possibly even as compared to metformin, as compared to the visceral fat. So the question was that does metformin exposure in utero get associated with a different pattern of fat deposition of subcutaneous versus visceral, and whether actually this would persist and be associated with differences in insulin sensitivity in the future. And this was the question then answered by the MIG tofu study at the 7 to 9 year mark in the offspring, which basically showed that the total and abdominal body fat percent and metabolic measures in the 7 to 9 year old offspring in both arms was similar. However, the 9-year-old offspring of women randomized to metformin was larger. They had a larger body weight, a larger waist circumference, arm circumference, and BMI than those mothers who had been randomized to insulin. So at the end of this trial, the safety of metformin for offspring still remains unclear. Another meta-analysis over here, basically, which following the intrauterine exposure to metformin for maternal GDM, basically showed that neonates who were metformin treated were smaller than those with insulin treated mothers. However, the important thing was that these metformin exposed children seemed to experience an accelerated postnatal growth, resulting in heavier infants and a higher BMI by the time they reached mid-childhood. And therefore, the impact of maternal metformin on the trajectory of fetal, infant, and childhood growth is still very unclear. What do all the society guidelines say? Well, the FDA basically has put metformin in category B, but at the same time stating that there are no corresponding well-documented studies in pregnant women. The WHO says it's acceptable, but second line, and of course, should be used in resource-limited areas where insulin has logistical issues. The IDF again says the same, but all the same, they say that metformin use is not recommended as first-line therapy when diet is inefficient before 20 weeks and fasting exceeds 110 and PP more than 140. The ACOG in 2018, the ADA in 2020 recommended insulin as first-line, metformin remains second-line treatment. And finally, even with the ADA, they basically said that even metformin, when used to treat PCOS and induce ovulation, should be discontinued by the end of the first trimester. The FIGO recognizes that insulin should be the first-line treatment also in developing countries such as ours, where one of the following occurs. If the diabetes is diagnosed before 20 weeks, if diet is insufficient for glycemic control prior to 30 weeks, and if the fasting exceeds 110, PP more than 140, and body weight more than 12 kilos, which pretty much covers all pregnant women. The Polish Association is very clear: do not recommend any oral drug, including metformin and GDM. And in women, in fact, who are on metformin, it is recommended to begin insulin therapy as soon as pregnancy is confirmed. It is only the British NICE recommendations who talk about metformin as first-line therapy when glucose levels do not stabilize after MNT for 2 weeks. Even in them, insulin will be recommended when metformin is either contraindicated, unacceptable, or is unable to meet glycemic targets. The NICE, although, recommends immediate treatment with insulin with or without metformin to women who have a fasting more than 126 or above at diagnosis itself, or even at a lower level if there is complications like macrosomia or hydrangeas. So then, in conclusion, well, if today I have a choice, and I'm not saying that metformin is not a choice. Metformin is a choice. However, it should not be the universal choice. It is a conditional choice when there are problems with literacy, with logistic limitations. Yes, we do want to give our patients something, but we should not possibly shirk from our responsibility of offering our patients the best possible treatments. We do not want these 199 million women with diabetes giving birth to another future generation with diabetes in itself. And basically, timely action taken right now can help India not become the diabetes capital of the world. Thank you very much. And with that, I will stop sharing and hand over the podium back to Girish.
Girish, it is over to you now. You have some problem with your internet, so now you can start.
Thank you very much. Sorry, sir, for that technical glitch, which was beyond my control. Well, I think half my job is done. And I said at the onset itself, I think this is a dialogue, and true to the spirit of we endocrine care team, I think it's a dialogue and not a debate. So both of us are presenting different versions and different aspects of therapeutic options available to us for the management of gestational diabetes. And I think I'm not going to spend much time on these slides because I think Dr. P has covered them. But yes, metformin, there were concerns. It's a quite safe, quite effective drug and oral molecule compared to insulin, which I would say has an issue. Insulin has remained the gold standard of treatment. It's effective and a safe molecule, but definitely there are limitations in terms of hypoglycemia risk, weight gain associated with it, logistic issues, multiple daily injections, psychosocial stress that comes with handling insulin devices per se, and the regimen per se. And therefore, if we have an alternative like metformin, obviously we need to wait and look at the options available to us. Metformin, an orally acting biguanide, quite effective. It works at a cellular level, as we all know. It basically uncouples the TCA cycle from ATP production, leading to an increased activation of AMPK pathway, which is itself associated with decreased gluconeogenesis, impaired glycolysis, increased fatty acid oxidation, decreased lipogenesis, decrease in reactive oxygen species production, and decreased endothelial dysfunction, reflecting the beneficial effects that metformin has. When it comes to pregnancy, there are limitations because what we are worried about is the transplacental passage of metformin, 50 to 70%, though maternal milk secretion is less than 1%. But keeping this in mind, the question always arises that is metformin safe? We understand efficacy, but is it safe during pregnancy? Well, animal studies at 2 to 3-fold the maximum recommended doses in humans have not shown any teratogenic effect. And keeping this in mind, the US FDA categorizes metformin as a class B drug during pregnancy. There have been a lot of studies right from 1984 until now, I think, looking at safety of metformin during first trimester, and all of them have been quite reassuring in terms of teratogenicity. There's no untoward teratogenic effect seen with metformin so far. Dr. PR did show you the mixed style, which basically lays the foundation for usage of metformin during pregnancy. It's a very nice study done way back, published in 2008 in NEGM, and they looked at neonatal outcomes as a primary composite endpoint and maternal and other metabolic parameters as secondary composite endpoints. And at the end, they concluded that with metformin, there was a better 2-hour postprandial glucose control, better weight management, there was less weight gain, and more weight loss postpartum, which is very essential as far as maternal benefits are concerned. Women were more likely to choose metformin initially and then maybe insulin. As you know, Dr. PR did show that a good number of patients, 46% of them, needed insulin therapy in addition, but at least to start off with, it's a good molecule. And 59% of those women who participated in the mixed trial said that taking metformin was the easiest part of the management plan. As regards to the offspring effects, especially those who were exposed to metformin, you have the 2-year, 7-year, and 9-year study, which Dr. Pia spoke about. And yes, at 2 years, in children exposed to metformin, they had larger measures of subcutaneous fat, but then the overall body fat was same as those who were insulin. So it was redistribution of fat, which was per se that was seen. even at 7 years and 9 years follow-up. At least if you note that this study was done in Australia and New Zealand, and in both these set of patients, there was a differential effect seen in the offsprings. In the adult subgroup, mothers were similar at enrollment, and women who were randomized to metformin versus insulin had higher baseline glucose levels compared to those who were on metformin. At 7 years, there was no difference in the offspring in the adult subgroup. Whereas in the Auckland subgroup, there was some difference. At 9 years, metformin offsprings were larger by measures at weight, arm, waist circumference, waist hip ratio, tricep skin fold, no doubts about it. But they concluded that probably metformin or insulin for GDM was associated with similar offspring total and abdominal body fat percent and metabolic measures at 7 to 9 years. Though in one subset of patients, the children who were exposed were large comparatively, but then at baseline per se, these women had a higher body mass index compared to the insulin arm. After the MIG trial and the MIG tofu follow-up trial, there have been a lot of studies, the MITI trial and the Empower study, which again documented safety of metformin during pregnancy use. There have been a lot of meta-analysis, and this is just a snapshot of the 2017 meta-analysis, which basically says that as far as safety is concerned, it's a good effective molecule. It's safe. Children in metformin arm, you have a lot of maternal and neonatal benefits. As far as maternal benefits are concerned, the weight gain that is seen is relatively less. Yes, the incidence of preeclampsia, pregnancy-induced hypertension are comparatively less, though there's a slight tendency towards preterm delivery, which has been noted. In terms of neonatal outcomes, the benefits in terms of lesser incidences of neonatal hypoglycemia, lesser NICU admissions have been noted by all these systemic meta-analysis, I would say. This is the last, which even Dr. Pia showed, 2021, Terry Atkins' systemic review published in Nature. And if you were to look at parameters like gestational weight gain and baseline maternal obesity or diabetes in pregnancy versus glyburide, all of them favor the usage of metformin. There's lesser weight gain seen with metformin compared to the insulin or glyburide arm. In pregnancy-induced hypertension, there are trends suggestive of decreased incidences of pregnancy-induced hypertension as well as preeclampsia in whichever subset you want to see. Yes, preterm delivery is what has been reported and noted in all these systemic analysis by about 1.7 to 4 days, I would say so, with metformin. And therefore, few guidelines do recommend metformin. If you look at the UK NICE guidelines, it talks about metformin to be used if glycemic targets are not attained with lifestyle modification within 1 to 2 weeks, and insulin is to be used if metformin is not tolerated. After metformin, insulin may be needed in few, especially it should be started if the fasting plasma glucose is more than 126 at the onset itself, or there are complications like such as macrosomia or hydramnios, then insulin would be a rescue therapy. Even the Endocrine Society 2015 guidelines say that metformin can be considered in women who decline or cannot use insulin or glyburide and are not in the first trimester. So even over here, they do endorse that it is a therapeutic option available. The FIGO guidelines, which Dr. Pia showed us, it also acknowledges that metformin is safe and effective therapeutic options during the second and third trimester. However, insulin should be considered as a first line, especially in these following conditions. That if you have a diabetic patient before the 20 weeks of gestation, if you have high glucose levels, if your pregnancy weight gain is more than 12 kgs, then probably metformin will not be that effective because it's all said and done a mild drug. So if you were to compare insulin versus metformin, I think if given an option, it's far easier to handle metformin compared to insulin. And the benefits of metformin are definitely there vis-a-vis insulin. But obviously control with insulin is something which is significantly better and many patients may need as a rescue therapy. So these are my last two slides where I've basically summarized the pros as well as the cons for metformin therapy. It's a good insulin sensitizer, but has a mild activity and may fail, especially in insulinopenic state. It's easier to administer, oral route, easy dose titration, but obviously tolerating can be an issue, and a concern is the significant placental transfer. Efficacy wise, its glycemic control is as comparable to insulin or glyburide, low risk of hypoglycemia, but it may not be adequate in about 14 to 46% of patients requiring supplemental insulin therapy. Well, if you look at the social and other considerations, metformin definitely has a better patient acceptability, low cost, and less need for self-monitoring of blood glucose. But at the same breath, I would like to mention that it's not approved for usage in pregnancy. It's still a category B drug, and usage is an off-label indication. Guidelines, the ADA does not endorse it as of now. As a second line option, it is still possible, but the guidelines per se are discordant, and that's why this dialogue. In terms of benefits on maternal outcomes, as I said, there's less risk of hypoglycemia, lower maternal weight gain, less risk of PIH and preeclampsia seen with metformin. Yes, slightly lower gestational age at the time of delivery is a concern that we all have to keep in mind and discuss with our patients. In terms of short-term fetal outcomes, there's no increased risk of teratogenicity. There's no increased risk of perinatal complications. In fact, there's reduced neonatal hypoglycemia, reduced NICU admissions, and reduced risk of large for gestational age and macrosomia. The risk of preterm birth is being there and accepted. In terms of long-term exposure, there's no evidence of growth or motor or social developmental abnormalities. In fact, I would say that if you look at the MIG tofu follow-up studies, the redistribution of fat may actually be a beneficial effect, though it's too preliminary to say because we have only one study looking at offsprings on a long-term basis. There are some concerns as regards to impact of metformin on fetal programming. There's reduced testosterone secretion and Sertoli cell numbers in mice seen, but its significance in humans is not being documented. And there are human studies looking at offsprings, and they've all been quite reassuring, I would say so far. So I would like to say that metformin is an acceptable option in gestational diabetes. It may be used as monotherapy, especially in mild cases when diet and exercise regimen is inadequate. And especially in those patients who refuse insulin, it may be considered. We need to keep in mind that all said and done, it's a mild drug, and good number of patients may require rescue insulin therapy. Thank you very much for your patient listening.
Thank you, Dr. Parmar, for a very lucid presentation. I think both the speakers have done a great job. Till we get some question, we can take the opinion of our senior endocrinologists like Dr. Sriram and Dr. Dharamlingam in short. Madam Sriram, over to you.
Thank you so much, Dr. Sharma. So nice to see you. Okay, both of you have done a marvelous job. And first I want to say, you hit the nail on the head saying, in the spirit of we, it is not a debate, but a duologue. And I actually insisted on that. Because debates are about debaters, and this is about issue. And we want to have a dialogue and not a debate. So that's great. Second thing is, I think you brought out the points really well. The one thing that I want to add is, we talk a lot about not wanting the mothers to gain weight. One of the big issues in India is that lots of mothers are underweight. And there is a secular trend for baby weights to actually go down, and which will then again further feed into this future type 2 diabetes and other metabolic issues. So I'm just saying, and like you very nicely said, metformin should be for people who will not or cannot take insulin. I'm just flipping the script and putting it the other way. Metformin should be for those who cannot or will not take insulin. And second thing is, each individual woman, I mean, it's not a monolith. Every pregnant woman is not the same. So you have to individualize tailor the treatment. If she is thin, if she has had a small baby before, or if she has had preterm labor before or issues, I mean, absolutely, I think we should put metformin way down. Nice guidelines are typically cost driven, and US guidelines are typically market driven. So I think we should find the balance between based deeply rooted in science. So that's all I want to say.
Thank you, ma'am. Thank you. We can take the opinion of Dr. Dharmalingam also.
So yes,
Yeah,
I fully agree. I think both of them have put their points forth, but yes, it depends on the person who's sitting in front of us. And like Dr. Usha said, there is that patient who says, no, I do not want. But however, I will be very comfortable to give metformin only after the 24th week. Before that, no, I wouldn't be comfortable. I'll counsel, I'll cajole, I'll plead, and I'll put her on insulin if it is the first 3 months of pregnancy. So that would be my take. Thank you.
Thank you. So I think we don't have any questions for this lecture. So we can go to Dr. Sandeep Julka. Dr. Damodaran is there or not? I have not seen him.
He's joined back. He is there.
So Dr. Damodaran, over to you for introducing our friend Dr. Sandeep Julka.
Thank you, everyone.
Thank you. Thank you, everyone, for this warm welcome.
Can we have Dr. Sandeep's slide, please?
Dr. Sandeep has to, yeah.
Dr. Sharma, if I think you can just introduce, I not
okay.
See,
so Dr. Sandeep Julka is a very good friend of all of us. He is a very jovial personality, very, very big-hearted person from a army background, I should say. And his old photo is showing his small mustaches, but now he has grown it very big as he's growing in his stature. He is MD DM endocrinology, head of the Department of Endocrinology from CHL, that is Chautharam Hospital, I think, from Indore. And he has achieved many achievements and awards, publications in Index Journal, phase 3 and 4 clinical trials since 2008. He is part of 2 cardiovascular outcome trial, and one of the trial was with tirzepatide, and runs a diabetic outreach program, Madhumeh Sarthi, and reaches out to patients in lockdown, especially women and gestational and pre-gestational diabetes. Dr. Sandeep, over to you for your talk on diabetes and fertility.
Thank you, sir. Yeah, I unmuted myself. Thank you so much. First of all, like to thank WeCare for this wonderful initiative. Are my slides visible?
Mm-hmm. Yes.
Visible.
Sandeep, but you need
have to make them full screen.
Full screen.
Is it okay now?
No.
No.
Slideshow.
Slideshow.
I'll do it again. Just a second.
There is an option there, share. Yeah,
yeah, I did. They're visible?
Yeah, now it is okay. Please,
so I'm very well aware that we are running little behind schedule. So my topic is diabetes and fertility in women. Before we go on to that, this is a very old and a wonderful shlok. If it resonates with everybody in the world, I'm sure gender bias and gender inequality will not be there. Indore is now a very, very big hub of fertility clinics. And I happen to sort of cater to so many of the patients who come to me with infertility. And I was referred this patient by one of a very bright and young fertility specialists. And if you read, it says, referring patient Neelam, who has PCO with hypothyroidism with increased HbA1c and infertility. If you have to see this patient of ours, you see that the lady is 34 years of age. She weighs 85 kgs and is 157 centimeters in height. So her BMI is definitely beyond 35. She's borderline hypertensive. She's pre-diabetic already. She's on metformin, although the doses are less, and she also has hypothyroidism. So she had acanthosis. She also has oligomenorrhea. So she has PCOS. We also need to work her up for NASH and dyslipidemia. So what is happening in this patient is that she has PCO, which is the most common hormonal disorder in reproductive age. She is insulin resistant. She also is bordering on diabetes. She is obese, and we know that obesity itself can lead to infertility. I spoke to some of the fertility specialists. They said the oocytes drawn from an obese woman don't do very good as blastocysts. And of course, she has hypothyroidism as well. So this basically lays out what we need to talk about in a diabetic woman, whether it is type 1 or type 2. This is the flow of the talk. I'll be touching on these points one by one. And we all know that fertility outcomes in women with diabetes tend to be more childless. And not just that, the pregnancy outcomes are also affected. Diabetes affects both the male and the female fertility. And we spoke about, I think Dr. Bharti Kalra spoke about genital infections. And this also leads to dyspareunia, probably also leads itself to infertility, recurrent genital infections. And I put a star here because we have to be a little careful, because we use a lot of SGLT2 inhibitors. We need to be careful that could they lead to more infections in the genital tract and probably affect fertility? Not sure. Basically, diabetes affects everything: the onset of puberty, the menarche, the cycles, the pregnancy outcomes. It affects the age of menopause. And as we know that, as we used to study in our UKPDS trial, that 1% rise in A1C caused 30% increase in microvascular injury. Similarly, 1% rise in A1C leads to 5 days longer menstrual cycle. So just to underline the fact that glycemic control is very, very important for a lady planning pregnancy. This table just shows us that it is not just the fertility part which is affected. After the lady becomes pregnant, insulin resistance, and type 1 diabetes or type 2 diabetes or gestational diabetes can have preeclampsia risk, miscarriage, cesarean delivery. And after delivery, type 1 diabetic women have 5 times higher risk of stillbirths and 10 times higher risk of congenital malformations. And similarly, the risk in type 2 women is approximately 2.5%. And we all see so many girls coming to us in adolescence with type 2 diabetes, vacancies, obesity, PCOS. So the incidence is just going to keep on rising. When you see this picture here, I think diabetes affects everything. If you start from the genital tract, it affects the uterus vasculature, the endometrium, the ovarian steroidogenesis. It affects the pituitary, it affects the hypothalamus. So we have to basically take into account all places. We all know that ovary has insulin receptors and IGF-1 receptors as well. There have been studies in mice animal models that diabetes can itself, due to it being an oxidative state, lead to decrease in angiogenesis and apoptosis of the granulosa cells, of course leading to anovulation. Now this is regarding type 1 diabetes, and it wonderfully lays out the lifespan of, in fact, pre-insulin era and insulin era, and then intensification of insulin through insulin pumps and MSII. Prior to insulin, the pregnancy rate was just about 2%. Then insulin gradually came, and then the girls started having menarche at the proper age. But again, there were some irregularities in menarche, and then came the phase of intensification of insulin, and something what is known as a secondary PCOS, which I was not aware of. I came across this in almost all articles. This came where the hyperinsulinemia, which was due to the insulin administration, led to hyperinsulinism, leading to anovulation, larger ovaries. And in Diabetes Care 2016, the pooled prevalence of PCOS in type 1 was 24%. And I was just wondering, I started putting all my adolescent girls on metformin. It makes sense now. Now, this is how type 1 diabetes affects the fertility. So there are two parts to it. If you see here, it is what we already know. Like anorexia nervosa, type 1 diabetes also causes hypothalamic amenorrhea, and that can be corrected by giving kisspeptin. And this is all what we know. But what you see here is very, very important. We all know that insulin secreted by the pancreas goes into the portal circulation. 50 to 70% of it is removed, and whatever is left is working. But when you inject insulin, everything goes, it bypasses the first pass effect of the liver, and there is exogenous insulin, hyperinsulinemia, leading to everything what you see. But here, what is different in PCOS of type 1 diabetes is that since there is the SHBG is not reduced, what you see in type 2, and also the DHEAS is not high. So there is, you may have delayed puberty, delayed menarche, and early menopause. So there was a study just to find out that the menopause is 10 years earlier in type 1s compared to their girls, non-diabetic sisters, and controls. What happens in type 2? Now, this is again a very interesting thing, that insulin is actually a co-gonadotropin, and it acts to increase the pituitary responsiveness to GnRH. It increases LH-FSH, and that in turn leads to increase in steroidogenesis and increase in androgens. And of course, you have hyperinsulinemia, then you have hyperglycemia. Hyperglycemia itself then causes lots of problems with the ovarian steroidogenesis. What I came across is that hyperinsulinemia causes downregulation of insulin receptors in the ovaries. But then what are upregulators is the IGF-1 receptors. So there is an alternative pathway which takes over and causes increase in steroidogenesis and hyperandrogenism. What can be done? Probably this is the most important slide. What can be done for improving fertility in women with diabetes? So the mnemonics for women is: one, work together, start early. You have to partner the woman in her journey to health and conceiving, and then in conception and bearing a healthy child. You have to work with the extended family member, because as stated, if, for example, there is a joint family, if you don't counsel the mother-in-law, the father-in-law, it doesn't help. Second is to address obesity. Obesity can be primordial. You can address it primordially. Have a healthy delivery so that the child does not become, we all are aware of fetal origins of adult disorders. As Dr. Priya said, that children given metformin and otherwise also children born to women with gestational diabetes tend to have higher incidence of metabolic syndrome. So primordial, primary, secondary prevention of obesity is important. What medication you use to treat is again important, because A1C weight paradox. 1% reduction in A1C leads to 4 kg weight gain in our usual drugs. But the drugs which we have now is GLP-1, SGLT2, metformin. You can probably choose these drugs over the others. Third is the diabetes therapy by the ear, as Dr. Sanjay Kalra tells us. Educate. Preconception counseling is very, very important. And if you don't counsel, for example, a child planning, Dr. Rajeshri spoke about counseling for pregnancy, because the cycles are anovulatory and irregular, and the lady will suddenly become pregnant and come to you with an A1C of 11. And she is elderly, primary, you can't even tell her to abort. So you have to be very careful. And there are studies to show that there is clinical inertia. We doctors don't talk about it. And of course, neonate, that is fetal origins of adult disorders. Coming on to the ovulation induction, we have all grown up giving clomiphene, but now the drug of choice is letrozole. We all know how they work. But metformin is a facilitator, and most of the infertility specialists swear by it. So I think metformin is a drug of choice, along with letrozole or in clomiphene resistant cases. If the clomiphene and letrozole fail, then you have gonadotropins. Basically, I leave this to the fertility specialists to use these. And then they do, and then of course they can, and if this fails, then do IVF and ICSI. ICSI stands for intracytoplasmic sperm injection. And that also takes away a lot of problems with the penetration of sperm in the ovum and all. And they actually told that obesity per se may lead to poor blastocyst formation. And I came across this article from Iraq, which says that probably the incidence of diabetes in women treated with IVF is 1.5 times higher. So we have to keep that in mind, whether it is due to the fact that women we have who are insulin resistant come to the fertility specialist, or is it due to the fact of drugs which are used for fertility? So there is a love-hate relationship between insulin and fertility. Insulin, if you don't give, causes hyperglycemia leading to infertility. If more insulin is there in both in type 1 and type 2, leads to hyperinsulinism, just as Amrish Puri can be a good and a bad father. But ultimately, I feel that metformin seems to be the shiro, because whether it is type 1 and type 2, I think we should give metformin to our adolescents. And nowadays, we've seen adolescents with acanthosis nigricans also with type 1 diabetes. So ultimately, I think it is teamwork. Have a good rapport with your obstetrician colleagues. And like we have, this is my gym. They're all three of them are fertility specialists. And this is my team. You should have a team, because managing type 1 diabetics in pregnancy is a difficult task. And unless you have a team, results will not be that good. Thank you so much.
Thank you, Dr. Julka, for your beautiful but crisp messages. We can go to our coordinators, first to Dr. Mala Dharmalingam for her opinion, and then to Dr. Shriram. Madam, unmute, please.
Yeah. Yes, fertility in diabetes is very, very multifold. And as Dr. Sandeep was saying, it is really important that we should have a team. In our team, we have a rheumatologist, we have an IVF specialist, we have a genetist, and myself. So we look at every complicated infertility patient, and we go through all the whatever needs to be done. And yes, I think the correct systematic approach is very much important. Over to Usha.
First, I have to tell you what an amazing talk. Very extremely good.
Thank you.
Quoting excellent papers and very beautiful flow of talk. It was excellent, and I think you have covered pretty much everything. The only thing I again want to say is that there is what we should not do is put everything in a pot and stir it, which is what happens in infertility a lot of times. A little metformin, a little letrozole, a little bit of this and that, and stirring the pot, hoping that one of them will click, or it'll click cabergoline, maybe for a little touch of prolactin being high. Instead of that, I'm just saying, like you said, if we can have a nice algorithmic approach and see, is it genital infection? Is it an anovulation issue? Is it something else? So if we can go through it, the whole thing very systematically, I think we can help our women a lot more than having this kind of an approach. But thank you for a great talk.
Thank you, ma'am. Thank you very much. I have seen Dr. Damodaran. Over to you, Doctor, for introducing our next two panelists. Two dialogue speaker.
Good afternoon, everyone. Thank you for the opportunity. Sorry that I was in another meeting. Can I got an extreme pleasure in introducing Dr. Yagdeep Gupta, and Doctor is from AIIMS Delhi, and he's well known in our field, and he's an RSSDI Novartis Young Investigator Award in 2020, and he's got the Anil Sheth Award in 2020 again by ESI, and AIIMS Excellence Research Award in 2019. with that small brief introduction, because the publications and other things goes on for a long time, but I think it is a pleasure, Dr. Jagdeep Gupta and Dr. Pramila Dharmashaku from Panchakula. I also got a pleasure in introducing. She's got 15 publications, both in nationally and internationally, and the ESI AV Gandhi Award in 2012. And also she's got good research work in her background nationally, internationally. With that brief introduction, I will ask the speakers to take over, please.
Yeah, thank you so much. Very good afternoon to all of you. Thank you so much, sir, for your kind words. At the outset, I would like to thank the organizers for giving me this opportunity. It is indeed my pleasure to be the part of this Women Endocrine Conference and to speak in front of the stalwarts. So I'll be sharing my screen. So I hope my screen is visible to all of you.
Yeah, it's visible.
So, I think we all have come across many women with diabetes, especially type 1 diabetes, who put in a tremendous effort in managing their diabetes. And at times, many of them face challenges. They face feelings of concerns regarding their glycemic management, their previous pregnancy outcomes, their pressure to achieve a good glycemic control, and desire for normal pregnancies. And even despite all their efforts, many women are unable to achieve a guidelines recommended glycemic targets. And we would also agree that over the decades, there have been advancement in the management, the care of diabetes. So in the same line, we would like to discuss in today's presentation the newer technologies in the management of diabetes during pregnancy. So just an overview of my presentation. Yeah. So we would be discussing about advancement in the glucose monitoring system, advancement in the insulin delivery methods, use of telemedicine or mobile health applications in the care of diabetes women in pregnancy. And we would also discuss some real life situations or practical aspects of some cases. So first of all, the continuous glucose monitoring system. So continuous glucose monitoring system is one newer technological advancement in the care of diabetes. It has a continuous glucose monitoring sensor. There are 3 components. In the second image, I think we can very well appreciate the 3 components of the continuous glucose monitoring or CGM device. There is a disposable needle-based sensor. Disposable needle-based sensor, which usually inserted and subcutaneously, it records glucose concentration in the interstitial fluid, and it generates almost 300 readings in a day. Then there is a transmitter which communicates the measured glucose. It is usually placed over the sensor and it communicates the measured glucose to a receiver. Now, receiver is a portable device which could be insulin pump, a smartwatch, or mobile phone. It visualizes the glucose readings to the monitor, whereby we can see and we can download the data. So this continuous glucose monitoring system, it is usually worn 7 days to as long as 14 days, depending upon the type of device. And as an alternative, there is a flash glucose monitoring systems also available, which is factory calibrated, because in the CGM device, we need to calibrate it at least twice a day. So if FGM is factory calibrated, it should not be considered as an alternative to CGM, but as a replacement for self-monitoring of glucose. The main difference between continuous glucose monitoring system and FGM is there are no alerts. There are no alerts for predictive low glucose or low glucose. There are no alerts for hyperglycemia or alarms for hyperglycemia. And also it cannot be integrated with insulin delivery system. So one of the ways this real-time continuous glucose monitoring system works is they allow us to see the effects of various activities or the food, lifestyle change, or insulin doses in a real scenario on their glucose parameters, wherein we can make some necessary modifications in our activities or insulin doses or in our diet pattern. So what are the key metrics or CGM derived parameters which we should use in clinical practice to assess the glycemic status of an individual? So CGM derived parameters, there are 5 CGM derived parameters. The first and foremost is time in range. Time in range is a CGM derived parameter, which is nothing but the amount of time or percentage of time a person stays in a given target glycemic range, that is 70 to 180 milligram per deciliter. The other 4 CGM metrics are level 1 hyperglycemia, that is blood glucose more than 180 milligram per deciliter. Level 2 hyperglycemia, that is blood glucose more than 250 milligram per deciliter. Level 1 hypoglycemia, that is blood glucose level less than 70 milligram per deciliter, and level 2 hypoglycemia, that is blood glucose less than 54 milligram per deciliter. So standard of care says that ideally our time in range should be more than 70%. The range being 70 to 180 milligram per deciliter. But as opposed to the standard care, the glycemic targets are a little tighter in case of pregnancy in order to achieve a good pregnancy outcomes. So the targets are defined and established in various guidelines. It has been published in Diabetes Care in 2019. So the target range is 63 to 140 milligram per deciliter, and the guidelines say that ideally a person should spend more than 70% time. The more than 70%, more precisely, it is 16 hours 48 minutes or 17 hours in a day. So a person should spend more than 70% in target range, that is 63 to 140 milligram per deciliter. Less than 25% of time should be spent in hyperglycemia, and less than 4% time should be spent in level 1 hypoglycemia, and very less time, that is less than 1% time should be spent in level 2 hypoglycemia, or there should be no episode of hypoglycemia. So we have a lot of evidences in support of continuous glucose monitoring system in pregnancy, but due to time constraint, we will not go into the details of many studies, but I highlight particularly this study. I think all are aware of this trial, the concept ancillary study, which is a multi-center open label randomized controlled trial, an international study which recruited women of age 18 to 40 years group with type 1 diabetes. And they were recruited at gestational age of less than equal to 13 weeks of gestation, or preconceptionally also women were recruited in the study. And the comparison was done between self-monitoring blood glucose and those who were monitored by self-monitoring of blood glucose with CGMS. So I'll come to the results. So as far as the glycemic parameters, glycemic difference and the glycemic targets were concerned, there were difference of HbA1c which was very low. It was less than 0.2%. The difference amount to be 0.19%, though it was very low, but it was significant difference at 34 weeks of gestation age between SMBG or versus SMBG plus CGMS arm. So SMBG plus CGMS arm were found to have a lesser HbA1c at 34 weeks as compared to those who had only SMBG. And pregnant women with the CGM users, they spent more time in target range, though the difference was less, 68% in those who were on SMBG plus CGMS versus 61% those on SMBG only. And there was significant improvement in the neonatal health outcomes with lower incidence of large for gestation age babies with fewer NICU admissions lasting more than 24 hours. And there was fewer incidences of neonatal hypoglycemia as well. After these studies, this has been incorporated in various guidelines also. American Diabetes Association in 2022 has also adopted this recommendation. They say that when used in addition to pre and postprandial blood glucose monitoring system, CGMS can help to achieve HbA1c targets in diabetes and pregnancy, although the level of evidence is weak. And CGMS metrics may be used in addition to, but should not be used as a replacement for self-monitoring of blood glucose to achieve an optimal pre and postprandial glycemic targets. So we'll just quickly take up a practical case scenario. A 20-year-old female with a long duration of type 1 diabetes. She presented to an endocrinologist at a period of gestation 18 weeks with A1C of 7.4%. She's primary gravida, and she's having this blood glucose log. So we can very well appreciate in this blood glucose log that she's experiencing multiple episodes of pre-meal hypoglycemias, and there has been significant glycemic variability. She's on insulin, conventional insulin actropate, that is 13 units in the morning, 5 units in the before lunch, 5 units before dinner, and insulin NPH is being given morning 6 units and evening 8 units. So at this point of time, I would like to invite Dr. Yashdeep Gupta, sir, just to know what should be the approach in managing such kind of patients, and also in women with hyperglycemia and pregnancy, what are the situations where we should think for evaluation using CGMS? And now that we have discussed that there are so many devices, including intermittent devices, the real-time CGMS devices, and also there are flash glucose monitoring systems available in the market. So, we talked about the advantages, but there are limitations as well, including their high cost, their need for calibration, and sometimes patients feel them bothersome for their alerts and alarms. So, so out of these systems, which system is the better for clinical use and implication? Over to you, sir.
Thanks, Pramila. Is my mouse visible? Cursor moving?
Yes, it's moving.
So basically, before going into the aspects, it's important that whenever there is a woman with hyperglycemia in pregnancy, the basic work is done. So when we talk about the basic work, means there is a diet, there is an exercise component, there is an insulin technique involved. So when I talk about the diet, it should be like quality, quantity, timings, and relation with the meals that has to be fixed and elaborated in detail. Similarly, when we talk about the exercise, duration and timings are important, and we need depth for the insulin technique. Once we have corrected the basic aspects and still we are not able to find answers to the problem, then we need to move to the technical technology parts. So in this case, the patient was worked up on these aspects and still we were not able to fix the problem. So we decided to put this patient on a CGMS system. You can see this is a Medtronic CGMS, which was a blinded CGMS system. So before I go into the details on the graph, what this patient shows, we need to be aware like what we are looking for parameters in the CGMS system when we put on a particular patient. So when a patient, we know that there is a prandial segment, there is a postprandial absorptive segment, and then there is a nocturnal segment. In the postprandial segment, the patient usually see a magnitude of rise, like what is an amplitude of excursion. Then we see rapidity of incursion, whether it is achieving that incursion 30 minutes, 60 minutes, 90 minutes, 120 minutes, or what sort of rapidity with which it's rising. Then we also look about the double peak. Double peak means, when I say double peak means when patient takes a breakfast, lunch, they're usually expected one peak which should calm down by 90 minutes. But there are some double peaks which shows that patient may be taking in between the two meals also. After this taking into the postprandial segment, then we look at the fall. It will be more clear in the next slide. We look about the fall. What is a magnitude of fall and whether patient is going into hyper or hypoglycemia or not. And similarly, after taking the glucose measurement, this information whether there is some additional peak or not, which there is some inadvertent snacks which may patient not be able to admit. So many times while evaluating patient on CGMS, we pick up this additional snacks by specific portions at specific time intervals by observing the CGMS graph. So these are the segments, and you know that after lunch, for example, we do monitoring at 3:30 or 4, and there is a segment from 4 to 8 which is not detected by SMBG with the conventional 6-point rating. Then again, this graph will show the information of hyperglycemic excursion during that time, giving another valuable piece of information. The another thing which we need to look about is a nocturnal segment. Even if the patient does 2 AM glucose metering and it shows hypoglycemia, it has been shown that there is a 1 to 4 hour period, which is maybe a 1 to 4 hour period of hypoglycemia before we detect hypoglycemia by conventional SMBG. So this graph again, rational value at what time the hypoglycemia starts, right? And similarly, the magnitude of dawn phenomena means early morning This is an additional piece of information that can come out from our CGMS system. So I think in nutshell, CGMS gives a lot of information beyond SMBG to interpret patients with hyperglycemia. Now you had shown that patient has a time in range parameters. In this case, we define as a time above range 140. You can see this graph which is showing that this patient was having 59% time which is spent in above range. Only 41% of the time as against 70% was spent within range, and there was no hypoglycemia. That the another parameters that you need to look about is the mean glucose value, which is 145 in this case. And I will show that the mean glucose of a normoglycemic people in Indian settings is around 95. It also gives an information for estimated A1C, which again can be looked and for means further evaluation. So coming back to this patient, so we did that by putting the CGMS, patient only spent 1% in the target range, and main problem was a 59% target above range. Next slide. Ramla, next slide.
So, start moving. Yeah.
So basically, this patient was evaluated out of a research study in which we put both Medtronic sensor as well as the Abbott Wala means Freestyle Libre Pro version to compare the accuracy between the two sensors, which is basically a part of our research project. So we had this opportunity of having graphs on both sensors. So the same patient, you can see what I was talking about, the magnitude of rise and the rapidity of rise. You can see that very sharp rise, postprandial rise that is happening in both three wheels. And there is a sudden sharp decline that is happening after the postprandials, and it is showing that the magnitude of drop is again very fast, and there are some hypos. But as we know that Medtronic sensor, and after evaluation, we found that Medtronic sensor is quite reliable as compared to the Freestyle Libre. So there was no hypo actually either on SMPG or either on CGMS system. So this was a pitfall key. Even when in the euglycemic range, the patients can have false hypoglycemics with the flash habit, and that has to be taken with caution. But this sort of information, this one, due to the graph, after extensive experience, we can judge the rapidity of fall and how it translates into the clinical practice. Like if it is a very sharp fall, sharp rise, and there is a significant sharp fall, this means we need an insulin which acts for a shorter duration of time, has a rapid onset of action and rapid peak, and then sudden fall, so that hypoglycemias can be avoided. So by understanding from this sort of graph, means all three means are showing sharp rises and sharp falls, we switch patients from conventional insulins to the PASP, this is fast acting insulin as part. And as you see that after switching, what was the 37 units of insulin, the patient's requirement came to the 19 units. So the insulin requirement came down, the log, the variability of the log decreases on the SMBG part, and there was no hypoglycemia even with the decrease in the glycemic values. Again, having said that the dietary history is very valuable part at each and every visit to further improve the outcomes of a patient. And the third part which has to be kept into mind is a gestational weight gain in pregnancy, which again adds a valuable information for the management plan. So next slide. So coming back to that patient on the CGMS, this is another 7 days graph, means after putting patient and switching to the PASP, which you can see that which was in 40s, the time in range, even just simply switching to the changing to the insulin, the patient time in range improved to 65%, and it is near to 70% what has been advocated by the guidelines. It should be noted in mind that even with the technology concept trial, which Pramila have shown, that only around 30 or 35% of the people in the concept trial, even by using CGMS, whole of the pregnancy, were able to achieve this sort of target 70% above in 1/3 of the patients. So there is a lot of scope of improvement. There's lot of scope in understanding and improving the management of such patients by the use of additional technical parts. And the mean glucose from 145 it decreased to 132. Again, you can see though we are able to achieve the target of 6.2%, but as I said that in our experience that mean glucose is 95%, 95 milligram. It is still very high as compared to the what we can see in the normal. Means there is a lot of scope of improvement even in this patient further. So next slide. So again, Dr. Pramila has shown you the graph where there is a more understanding on type 1 diabetes, but there is less understanding on type 2 diabetes and especially on gestational diabetes for time in range, time above range, time below range. So what the guidelines suggest that time in range should be above 90% for GDM for type 2 diabetes. This is a graph from one of our research patient, which I am showing. You can see that this is a GDM patient, which was put on a sensor. This patient has a mean glucose of 17 milligram per cent above what could be seen in the normal people. And you can see that 96% in target range without any treatment. So even though means the patient is well above the time in target range, the mean glucose is above 17 milligram from the normal part, giving again a lot of scope for improvement. So it's not like every technical aspects bring mere advantages, but it also needs a careful consideration when you interpret the data and just not carried away with what has been said in the guidelines. So there is still a lot of things that need to be generated in the field, understood, and then used for improvement of the patients in the context, right context. So answering one of the questions for the Pramila, so I will choose my candidates for the CGMS where I see the variability, where I have put a lot of effort in the correcting the diet, exercise, dosing, and technique related issues. And I see there is a scope for further improvement. If my time in range is 50%, I will definitely try to put, if I am a GDM patient where I anticipate it's 92%, 95% time in target range, I don't see at this moment a very good advantage of CGMS in such sort of patients. So next slide. So this is a graph which this was a DM dissertation work, I think colleague of Dr. Pramila, which did DM dissertation under us. So this is a value which we generated in the early pregnancy. In the normoglycemic group, it was 95 milligram per cent, and in GDM group, without any intervention, we observed that the mean glucose is 105. And what you can see is that the normal people spend more than 98% in time in range, and even in the GDM patients, nearly most of the patient will be above 90%. So this is not a right metrics to be used at GDM at the current level of understanding. Next slide. Pramila?
Yes, sir. So thank you so much, sir, for clearing the doubts and taking us through the practical insights of CGMS use. So we'll now come to the next technological advancement, that is advancement in the insulin delivery system. So insulin pump, the role of insulin pump has been established in patients with type 1 diabetes, and the benefits are, so we need to change the infusion set every 3 days. So instead of giving 3+ injections per day, the infusion set has to be changed every 3 days. So there is only one prick in 3 days. There is a finer tuned adjustment of basal insulin delivery. So we no longer there is a flat 24-hour profile of a basal insulin. And this also enables us for smaller increments for basal and bolus insulin dosing. And insulin onboard calculators help us to prevent stacking of insulin that could increase the risk of hypoglycemia. And the important function is the memory function of most pump, which allows uploading the data and review of the data in order to help with the dosing adjustment. And it also enables us to use temporary basal rate that helps us in adjustment according to the physical activity or at times of increased insulin demand, such as in case of illnesses or in the presence of ketones. And it also provides the foundation for automated insulin delivery systems. So as we have plenty of data available on CGMS use in pregnancy, we have plenty of data available on insulin pumps in pregnant women with diabetes. So this particular study is a systematic review and meta-analysis of 47 studies, including 43 non-RCTs. It was published in European Journal of Endocrinology. Reported almost 8,000 pregnancies were reported. This study showed a lower HbA1c level with the continuous subcutaneous insulin infusion versus multiple dosing insulin in the first trimester, but the difference decreased in subsequent trimesters. So compared to multiple dosing insulin therapy, the continuous subcutaneous insulin infusion resulted in a higher gestational weight gain also, and lower daily insulin requirement in the first and the subsequent trimesters. Moreover, infants from the continuous subcutaneous insulin group were likely to be large for gestational age and less likely to be SGA babies. So we have enough evidences in support of use of continuous subcutaneous insulin infusion in pregnancy, but we have data against the use of therapy wherein we did not find significant improvement in the outcomes. So one such study was published in 2019. It has shown that insulin pump use was associated with increased risk of large for gestational age babies and preterm neonates without any association with increased risk of adverse pregnancy outcomes. Another study have shown that there is no significant difference in the glycemic control or the pregnancy outcomes in women who were using continuous subcutaneous insulin infusion or multiple dosing insulin, which were managed in a multidisciplinary settings. Another study published recently in 2021 have shown that insulin infusion therapy did not correspond with the pregnancy outcome despite having better glycemic control in that arm as compared with the multiple daily injections in type 1 diabetic individuals. So based on the data, we have unequivocal data as we have discussed. So given this data, I would like to ask, sir, that in what sort of patients we can use insulin pump therapy as a mode of delivery, insulin deliveries. Over to you, sir.
Next slide. So one slide regarding that question. So this is one of our patient initially whom we put on the insulin pump. So I will choose my case after having a CGMS and understanding and addressing all other issues as I discussed, insulin titration or maybe use of analogs and having understanding from CGMS. And again, there is a good scope of improvement. So basically, when I see there is a segment, for example, if I give analog or the conventional insulin at the night, and there is a hyperglycemic segment and there is a hypoglycemic segment within the same duration, like for example, you have a 4 hours of hyperglycemia and then there is rapidly hypoglycemia, not amenable to insulin dosing adjustment. So when we see 1 or 2 such segments which are creating trouble with a dose adjustment, I think those are the candidates for the insulin pumps, because it gives the flexibility of giving multiple boluses to address multiple hyperglycemic excursion. And similarly, there is a possibility of adjusting the basal rates to prevent the hypoglycemic episodes at different times. So when you split more than 5 or 6 times insulin, I think that are the patients whom one should consider insulin pumps. So again, it depends upon the resources and patient's ability, but having this sort of situation, we should consider for the insulin pump these patients. Maybe next slide.
So thank you so much, sir, for explaining the practical aspects of insulin pump uses. So I think one of the most significant changes to the healthcare system during this COVID-19 pandemic has been the widespread use of telemedicine or teleconsultations. Specifically in endocrinology, in diabetes mellitus management has been found to be particularly well suited for this strategy. So in the same line, the telemedicine has also been used in patients, in pregnant women with diabetes mellitus. So particularly this study, which was a meta-analysis of 32 randomized controlled trials, about 5,000 women with pregnancy or pregnant women with diabetes were assessed in this study. And it was seen that compared to the standard care of therapy, telemedicine interventions can decrease the glycemic levels of patients with gestational diabetes mellitus more effectively, and it also reduces the risk of maternal and neonatal fetal complications. So this figure just illustrates the use of mobile health apps. We have numerous mobile health apps or mHealth pregnancy apps available for management of diabetes in pregnancy. So we have so these usually, how does it work? It has a dedicated GDM diabetes in pregnancy team, including the doctor or the diabetes educator, and it acts as a support between the clinical visits in order to reduce the number of clinical visits. So what all domains it has multiple domains, including informations or educations on diet and lifestyles, glucose monitoring system, weight monitoring, and informations on insulin or treatment. So patient gives data or puts the data on the app, and subsequent advice or feedback is being given from the team. It also includes the domains like stress management, which is very important in patients in pregnant women with diabetes. So it leads to improved self-management, better glycemic control, and appropriate weight gain. That leads to overall improved pregnancy outcome, higher satisfaction with care, and improved maternal well-being. So I would like to invite now, sir, to just give us a summary or the take-home messages. Over to you, sir.
Basically, the message from this presentation is that one should be aware of what are the new recent targets beyond SMBG and A1C. What are the targets for the gestational and type 2 diabetes? They are quite different from type 1 diabetes. One should understand the limitation of these targets, as I showed one of the slides for the GDM. Then one should be aware of advantages and limitation of particular technology. We are more aware we use the trends from the flash glucose monitoring for our management decisions on day-to-day basis. But blinded data from Medtronic is more reliable, and now we will be having real-time CGMS. Obviously, we have that in market. So again, we should be aware of all parametrics, metrics like mean glucose, A1C, and time in range, and try to improve each one of them, not just limited to one of these. Then we should choose carefully our patients for the insulin pumps, because each technology is technically demanding and will demand your time, both a doctor's time, team's time, and the patient time. So careful selection of the patient is important for optimal outcomes. Then there's a lot of scope of improving outcomes, because still CGMS and insulin pump launch has not shown that to improve outcomes what it has been anticipated. This means you need to interact more and more with the patient and to impulse, not to really have to improve these outcomes. Next slide. So I will just conclude by saying that adoption of technology without understanding is not a path for improving outcomes. And conversely, I will say that not using technology will not give you in-depth insights. So once you carefully choose your patients, learn, and then you will obviously be able to contribute more to the better outcomes. Thank you so much for your patience.
Thank you, sir. Over to the organizing committee.
Dr. Damodaran? I think Dr. Damodaran is not there. Thank you, Dr. Pramila and Dr. Gupta, for beautifully highlighting the newer techniques in dealing with this diabetes and pregnancy. So we can go to the next topic. If I can wait here for our comments from our coordinators, Dr. Dharmalingam and Dr. Usha Shriram. Otherwise, we will go straight to.
I think for want of time, Dr. Sharma, you can go on, and they've done an excellent job. So they've covered everything. So I think we can just go to the next.
Okay.
Thank you.
Okay. So next topic is the last topic among this part of our seminar, and it will be conception and pre-gestational diabetes by our friend Dr. Saptarishi Bhattacharya. Dr. Bhattacharya is there. So over to you, Dr. Bhattacharya. May I have your present introductory slide? Dr. Bhattacharya is MD DM Endo, FAC, and senior consultant endocrinologist at Indraprasth Apollo Hospital, Sarita Vihar, Delhi. He has so many achievements to his credit, and he is also one of the pillar in the very important meeting, that is SPEED meeting, which is having its deliberation every year. And he is scientific secretary, Endocrine Week, and more than 60 publications in national and international journals. So he will be speaking on conception and pre-gestational diabetes. Over to you, Bhattacharya.
Thank you, sir. So can I have the screen sharing rights? Yeah. I hope my slides are visible. So I will be talking on a very important topic of pre-gestation diabetes and conception. So we have been talking about diabetes and pregnancy for last 1 hour or so. And before going into the topic, I would like to congratulate the team of the We Care team. So there are so many great women who are there and they keep on inspiring us. So congratulations to the team for such a wonderful conference they have organized. So what is getting important now is that we keep on having the more and more type 2 diabetics who in the younger age. So we earlier had type 1 diabetes. So most maybe around 20 years back, most of our diabetes patients who are going into pregnancy are having actually type 1 diabetes. But we have seen that the topography and the epidemiology of diabetes has changed. So we get to see patients at age of 20 years, 25 years who have actually type 2 diabetes. And the bulk of our patients who actually have type 2 have diabetes before conceiving are actually type 2 diabetes right now. So it's getting more and more important that we need to understand that what are the risks of diabetes in pregnancy. So there are multiple risks. So if somebody goes into a pregnancy with uncontrolled diabetes, then there is a risk of spontaneous abortion. There is a risk of fetal anomalies. So a very important risk is that in the first half of pregnancy, at least in the first trimester, so if the diabetes is uncontrolled, there's an increased chance of congenital anomalies. So that is the most important risk which you need to understand. And obviously, there is a risk of increased abortion. And once we proceed further in the pregnancy, there is a risk of preeclampsia. So if the blood sugar is uncontrolled in the later half of pregnancy, there is a risk of macrosomia. And after delivery, there are risks of neonatal hypoglycemia and respiratory distress syndrome. So there are essentially 3 categories of risk. So first half of pregnancy or maybe first trimester of pregnancy, you need to look into the risk of congenital malformation if the blood sugar is uncontrolled. In the later half of pregnancy, you need to look into the risk of macrosomia. And after delivery, also you need to look into risk of certain complications like neonatal hypoglycemia, respiratory distress syndrome, and maybe increased chance of jaundice. So that will be after delivery. So these are important risks, and this is why we need to address. And maybe there is a evolving risk of epigenetic complications also. So women with diabetes who conceive, and if the sugars are not controlled, maybe after 10-15 years of delivery, the fetus, the child might have long-term complications. So that is another risk. We do not have that much of information till date, but there is still evolving information related to that we need to address that issue. Maybe we need to address the glycemic targets in diabetes for that reason also. So we have multiple targets before conceiving. So one is weight and lifestyle change. So that is the most important parameter. We have glycemic targets, we have blood pressure targets, we have lipid parameters and aspirin as well. So this is the ADA 2022 guideline. So I think the most important part before conceiving is the counseling. So the person has to know, the lady has to know that before conceiving, she has to go through some changes in her lifestyle. The glycemic target has to be achieved. A certain amount of weight loss has to be achieved. There has to be a definite meal plan. Maybe the blood pressure has to be under a certain level. Maybe if she's on some medications which are not indicated during pregnancy, that has to be adjusted. So I think the most important message is that whenever we are dealing with ladies who are younger, maybe at the age of 20-22, we are getting so many patients with diabetes. We need to tell them that whenever you plan your pregnancy, that has to start at that very time point. So whenever you get a younger lady with diabetes, you need to incorporate the plan for pregnancy right from your first visit. So these are important things which needs to be addressed. So this is very, very important that we start counseling for diabetes in pregnancy right from the day one. So it's not that you need to wait for somebody getting married. So if you get a young lady with diabetes at the age of 22 years or 25 years or 26 years, we get so many such ladies who have diabetes, and we need to start counseling. Even PCOS is a contributing factor for development of diabetes in pregnancy. So we need to address all those issues right from the beginning. So there are multiple parameters which needs to be addressed. So obviously the lady has to understand that there is a history with the pregnancy will increase insulin resistance. So if somebody is on insulin, the insulin requirement will go, it might remain the same or slightly go down in the first trimester. Then in the second and third trimester, most probably it will go up. At least definitely in most cases, what we see after 22 or 24 weeks, there is a drastic increase in requirement for insulin. So that has to be counseled. And we need to tell the lady that preconception glycemic targets that needs to be addressed. So diabetes is one situation. We have increased tendency for diabetic ketoacidosis. Pregnancy is one situation that, and we need to address that as well. And it predisposes to severe hypoglycemia because the baby is drawing glucose from the mother. So that is another situation we need to address. And diabetic ketoacidosis can be actually euglycemic also. So there are two situations where we can get euglycemic diabetic ketoacidosis. One is we keep on discussing about SGLT2 inhibitors, but obviously there is another situation where we can get euglycemic diabetic ketoacidosis is pregnancy. So you need to be very, very careful at that particular point of time. So any lady who is having any features of diabetic ketoacidosis should be addressed. So any vomiting in pregnancy should not be ignored. With diabetes should not be ignored as vomiting related to pregnancy. We need to rule out decay at that particular point of time. So fertility, we already had a long session on that. So that remains an important issue. So there are genetics of diabetes and risk to pregnancy. So we need to tell the mother that there are risks which are different in the first trimester and maybe in the last trimester. So in first trimester, we're looking at miscarriage, stillbirth, or congenital malformation. And in the last half of pregnancy, we're looking at macrosomia, preterm labor and delivery, and maybe hypertensive disorders. So the first target which we need to look into is weight gain and pregnancy. So usually it's like, normally for a normal lady, it should be like 10 kg. But if somebody is overweight, maybe we can consider a weight gain of 7 to 8 kg in the setting of pregnancy. And as of now, we do not have very, very strong data to suggest that what is the ideal weight gain for a overweight lady. But any lady with diabetes, we need to be sure that the person is not getting excess weight during pregnancy. That is very, very important. And the next important step is glycemic target before conceiving. So HbA1c should be less than 6.5%. In most of our pregnant ladies, we prefer insulin. So there are not very strong recommendations or strong guidelines related to what should be the ideal therapy just before conceiving. So after conceiving, we have a lot of therapy. So most of the guidelines will suggest insulin. There are some guidelines which can consider also metformin on top of that. So metformin has its advantages and disadvantages. So metformin will help to reduce the insulin dose at the time of pregnancy. And most probably but we do not know that how metformin is going to work after maybe 10-12 years. So the most of the confusion related to metformin is not related to just immediate point of delivery, immediate outcome after delivery, but maybe what is going to happen after 8 to 10 years, maybe whether it's going to cause childhood obesity, increased fat deposition. So these are areas which we still do not have an answer. But maybe my personal suggestion again will be at this situation. So if you are not able to control diabetes with a very high dose of insulin, you can consider. So it's a soft recommendation. We do not have evidence to support it. We do not have evidence to refute it. Maybe my personal opinion will be that if somebody is type 2 diabetic and planning a pregnancy, you have put the person on a basal bolus regimen, the sugars are still not controlled, you can consider metformin at that particular point of time. So, I think glycemic control is more important for most of the pregnant ladies rather than the insulin, rather than whether metformin will have some long-term negative effect or not. So my personal opinion is that maybe the insulin is the best treatment, the safest treatment. But if you're not able to control with insulin alone, so there are long-standing diabetics who type 2 diabetics actually, who at the age of 30 years, 32 years, or 35 years going into planning a pregnancy, and we were not able to control with insulin alone. Maybe there is a case for adding metformin at that particular point of time. And there's another subgroup of ladies who have infertility related to PCOS, and they often have associated type 2 diabetes. Again, this is another situation where metformin actually can benefit. And insulin is the gold standard, but whether you want to add metformin in this particular group of patients, it depends on your own personal practice. There is not much of evidence. Again, I'm telling to suggest that you need to add or discontinue metformin at that particular point of time. So another area where we need to look into, we just keep on, so if we keep on looking at the glycemic targets, but there is another area where we need to focus on. So these ladies who are planning pregnancy, so the epidemiology has changed. So they plan pregnancy at a later time, after 30 years, 35 years. So they often have coexisting hypertension along with diabetes. So the target blood pressure is around 110 to 135 for the systolic. The diastolic target is around 85. And most probably you need to avoid ACE inhibitors or ARBs and statins at that particular point. If somebody is planning to conceive, so you need to put somebody on medications which are okay with pregnancy. So most probably you need to discontinue these medications before conceiving. Another important area is that you can shift. In fact, so my personal preference is that, so if somebody is planning to conceive, rather than making too many changes at the so when you get to know somebody is pregnant, it's like 5 to 6 weeks already into the pregnancy, and that is the organ formative time. So my personal preference is that whatever changes you want to do, you try to start doing it before conceiving. Counsel the lady that this is what is required. But again, that is more of a personal choice. So we do not experiment. We cannot experiment too much at the time of pregnancy. So we actually need to look into situations where you can have a very smooth transition at the most important time. And the most important time is like 6 to 12 weeks of pregnancy. So if you are trying to make too many changes at that particular point of time, my personal opinion is that we should not be doing it. So I try to, on a personal basis, what I try to do is I try to counsel the lady and do most of the changes before pregnancy, rather than doing too many changes at the most important juncture of pregnancy. So atenolol is not clearly recommended during pregnancy. Methyl-dopa, nifedipine, labetalol, diltiazem, clonidine, and prazosin are the preferred medications. So again, chronic diuretic usage is not recommended. And so and statin should clearly be stopped. So this is one area where we actually keep on seeing our patients or ladies who have diabetes or maybe had pre-diabetes earlier and conceived. So we have ladies who have a fasting blood sugar, say in the range of 100, 110, 112, 115, not theoretically in the level of diabetes, but we do not know, and again, not qualifying for gestational diabetes right at the beginning. So these are ladies who obviously will qualify to be a gestational diabetic after 24 weeks, but we do not have any such criteria in the early half of pregnancy. So this is a gray area where we actually are looking forward to more studies where if somebody is having a fasting plasma glucose of more than 92 or an HbA1c on the higher side, so how we need to address them. So this remains a gray area. We do not have any strong recommendations or guidelines. primarily because of lack of evidence. So if you try to treat too aggressively, there is a chance of small for gestation age babies. If you do not treat, we do not know what is going to be the outcome, but this is something which we need to study in the subsequent times. And the most important thing is that if somebody has diabetes at the time of conceiving or later, so what are going to be the epigenetic changes? So how we do not know that how it's going to actually matter. So whether developing diabetes in the first half of pregnancy or a gestation diabetes is going to alter the genes. So again, this is a gray area which requires a lot of studies, and we do not have an answer for that. So finally, to summarize, I think the basic idea is that we know that somebody with diabetes might have difficulty in conceiving. Most probably, insulin is the safest option. If you are not able to control diabetes, as of now, we do not have evidence to support or refute usage of metformin, but most probably it's safe. I think most of our faculty will agree with that, but again, we do not have strong evidence. The A1C target is less than 6.5%, and you need to adjust the medications appropriately at the time of conceiving to avoid complications. So you definitely need to avoid statins, you need to avoid ACE inhibitors or ARBs, and also you need to monitor, even start an aspirin at the right time to prevent diabetes-related complications in pregnancy. Thank you very much for your kind participation, and I'll hand over the proceedings back to the organizing team.
Thank you, Dr. Bhattacharya. Since we are running late, short comments from our coordinator, Dr. Dharmalingam, and Dr. Usha Sriram. Short.
This is, thank you, Dr. Sharma. This is a very important topic of conception, pre-pregnancy conception. I feel that this is an area which is very not dealt on in much detail, because very often we do get that known type 2 diabetes also with coming to us after she has conceived, and with sugars and HbA1c of more than 6.57. And then we need to do everything in a hurry. We do tell them on and off that you should come when you are planning, but it usually happens that they come later. So I think it's a very important topic, and we need to deal in more detail about this. Thank you. Usha, your comments.
I agree completely with Mala. And nearly 1 out of 4 or 1 out of 5 women only, even in the best of centers in the world, are actually getting preconception care for even pre-GDM. So it is a huge gap. So that has to be addressed. And I think if the women know that the window closes within 8 weeks, the organogenesis window closes within 8 weeks. And so unless they do this before they get pregnant, by the time they come to the doctor, it's already 6-7 weeks or even 8 weeks. So the window is already closing, birth defects are increased. That maybe, put it gently across to them. I think it may be a good way to motivate them to make sure that they get all this done prior to the pregnancy. Thank you so much, Dr.
Thank you. Thank you, ma'am. It was a beautiful, you can say, seminar, and all the speakers have done great job, and your comments were always welcome. So I hand over the session to our organizers. Thank you. Thank you very much.
Thank you, Dr. Sharma, for all the coordination, and thank you very much.
Thank you, everybody. Thanks to the chairpersons, the coordinators, and all the speakers. That was an absolutely fantastic session. And we move on to the last session of the day. I wouldn't say those are last session. We all know it's going to be a very, very dynamic session, because it is being coordinated by none other than 2 very dear friends, Chitra and Tejal. These are all Tejal's official introductions, but Tejal is more than a friend. She's a person I reach out to when, I really am stuck about something. And she gives me some of the most dynamic and sometimes the most atrocious opinions also. So it's always a pleasure listening to Tejal. And Chitra, again, is a person whom I turn to for a number of reasons. And it's always a pleasure listening to both of them. So Tejal, though I am going to officially introduce you, the previous slide, please. Tejal is an endocrinologist, number of achievements. She teaches us a lot, learning from qualitative research to understanding digital therapeutics to creative writing, a huge amount of research, which she's now doing in doctor-patient communication, as we all know, and of course, PCOD, and a person who's extremely honest and absolutely down to earth. Also going to Chitra, as we all know, I'm going to soon call them as the dynamic duo or the Siamese twins, if I'm allowed to, with again, Associate Professor, Department of Endocrinology, Ramaya Medical College, Bangalore, a very close friend, number of achievements, more than 40 publications, co-author of Language Matters, with again, research interests in PCOS, doctor-patient communication in chronic disorders such as diabetes and obesity. So over to both of y'all. I'm really waiting impatiently to listen to you and learn from this dynamic team across over there. Over to y'all.
Thank you, Dr. Shaila, for the kind introduction. Could we just have the slides for the chairpersons? We are pleased to invite Dr. Anjana Bhan. Welcome to this session of lesser known needs. Could we just mute?
Muted.
Sorry. So first of all, thank you very much, this amazing Women in Endocrinology team, for the invitation to be part of the first WeCare annual meeting. And we hope to see everybody every year from now on. And a big round of applause for the amazing sessions we've had so far. PCOS is a condition that all of us manage in our clinic almost every single day. It's not necessarily an endocrinologist. It could be a dermatologist, a gynecologist, a nutritionist, a physiotherapist. All of us see women with PCOS every single day. We all know how to diagnose the condition, investigate the condition, manage it from a medical perspective. But I think often due to time constraints, unintentionally, we tend to let the emotional well-being of women with PCOS take a backseat. But I think that emotional well-being is probably the final piece in the puzzle, which puts the whole picture together. And it impacts how women experience the care they receive, and in turn, ultimately impact outcomes. As doctors, that's what we are invested in, that we want good outcomes for people with PCOS. We want them to have good physical health, good mental health, good social health, and a good quality of life. And I think meeting some of the lesser known needs of PCOS may very well help us to achieve what we set out to achieve, that is a good quality of life. I'm also very looking forward to this panel discussion. I'd like to invite Dr. Anjana Bhan as one of the chairpersons. Dr. Anjana Bhan is a senior consultant at Max Healthcare, New Delhi. She's a former faculty at George Washington University Hospital in the US, and she's an invited speaker at national and international conferences. Her areas of interest are diabetes, thyroid, and female endocrine disorders. She's also still enthusiastic till date. She wanted to know what are the questions we're going to talk about, what the discussion is going to be about. And it's very rewarding to have somebody who is so enthusiastic and involved. Next, please. Dr. Ashraf Ghani, I think right now the main is that he's the founder member of the PCOS Society. He has a huge amount of work in PCOS and a lot of publications which extensively investigate the medical perspective of PCOS. He has a lot of publications, a lot of awards to his name. And we're very excited to have him on board, because it's when the medical perspective and the emotional perspective come together, that's the time to achieve our outcome, which is quality of life. Dr. Ashraf Ghani, please go ahead.
Should I start?
Please, ma'am, go ahead.
Okay. Can you hear me? Because my mic said muted.
We can hear you, ma'am. Please go ahead.
Okay. So first of all, thank you very much again. I think thanks are in the order since yesterday. But I want to just add one more line here. And I am in total awe of all the amazing speakers that I've been listening to since yesterday, and the wonderful topics that have been discussed. I think we need a whole week to go over slowly with each session, and it's been a real treat. Here I also want to say I'm an old timer, and I did my fellowship in endocrinology and worked in the US for a few years over there before I came back to India. I'm an old timer and a low-key endocrinologist also, so that goes together. But as PCOS has evolved, so also has my journey into endocrinology evolved. I remember way back in the late 1990s, 99, 2000, when I was in the US, Jeanette or cyproterone acetate was not available at all. In fact, metformin, I had never used metformin there till I came back to India. And I saw metformin for type 2 diabetes, for PCOS being used right, left, and center. And I was really anxious about every time I wrote metformin on my prescription. I think cyproterone acetate, as in Diane, is still not available in the US. You know, they're very strict about many of their many therapeutic products. But anyway, I don't even remember how did we treat. We just treated them with oral contraceptive pills, you know, people who had PCOS who were diagnosed at that time. And the only one thing I do remember very clearly is that we sent them to a psychologist on our team. And the psychologist was a dietitian rolled into psychologist. And that was missing when I joined in India. When I started work in India, we sat across the patient and wrote all the medicinal products, but there was no support system. There was no psychologist. I was in a fairly sort of busy practice at that time, and I didn't have too much time to discuss all the nuances of how your mental issues or your anxiety issues and all that should be addressed. And over the years, I have evolved. My practice has also evolved, and I have learned to be more empathic, maybe more supportive, and all of that. So I won't speak a lot about this now. I know we have a panel of luminaries and experts to talk about this. Would you want me to introduce them, or would you go ahead with the introduction?
Ma'am, if you could just have a word, Ashraf Ghani, and then Dr. Chitra will come, and she has a survey that she wants us all to take.
Okay.
Yeah, good afternoon, everybody. It's heartening that women in endocrinology are in India are making a dent. So first of all, let me congratulate the women, belated happy International Women's Day. And of course, endocrine diseases are also making women to suffer, but there are significant number of women who are going to support the women in India. So we, in between, some men are also playing the part, and I am very fortunate that I am also involved in PCOS some way or the other, whether it is research or awareness. So let me, as Dr. Anjana told, that PCOS was not being treated well few years back, and not much knowledge was available. Now I did my DM, and my DM thesis was on PCOS, and how I selected that topic was the first paper of use of metformin in PCOS. I did a journal club, and that is how my topic was chosen. I chose that topic. So since then, there are a plethora of publications coming on PCOS. I think day in and out, the research papers are coming. We are definitely understanding it better now. It is not just women who are affected. I think the whole society. It is the neonate, fetus, the male members, and all the people have similar affection by the disorder. I do not think it is just a women issue. So male members of the same families have significant metabolic consequences. I want to inform you that we are trying to do our bit. We have created a registry of PCOS for understanding the real world scenario of practice of in endocrinology and practice by other specialties in terms of PCOS. So that we have launched through our society called Metabolic Syndrome Pre-Diabetes PCOS Society recently. Many of you must be the members of that. And I'm sure a year or two down the line, we will have significant understanding how the PCOS is being managed in India. I also want to inform you that we have started this national task force through ICMR, and there are almost 20 centers contributing data, and it is a flagship study probably in the world. And we will be able to give interim results in the next 2 to 3 months about how common PCOS is, what are its metabolic consequences, comorbidities. So I'm sure that we will put our effort, we will put our heads together to contribute for improving the care of women in this. So in this session, we have expert group, which are, I'm sure they will do justice with the topic. Very wonderful people, 4 or 5 people who have done good in research and PCOS. And I would request my co-chair, Dr. Anjana, to start introducing them. And I will be there, that we will be in between moderating the session. Thank you.
Thank you. Thank you. So Tejal and Chitra, do you want me to introduce them? Can I have the slide if...
yeah, you can, ma'am, introduce.
Okay.
Please, can we have the slides back, team? Intro slides, please. Thank you.
Okay. So it's my real pleasure and privilege and honor to introduce this galaxy of speakers for this topic. And this is Dr. Mahati Chittam. She's an associate professor of health and medical psychology in the Indian Institute of Technology, Hyderabad. So she will bring a non-medical perspective to the whole picture. Her research interests lie in the domains of psychosocial cancer, diabetes, women's health, and health behavior. Her expertise within these areas is in unpacking cultural contexts of care, improving communication skills amongst physicians, patients, and their caregivers, and helping patient empowerment. Topics very close to my heart. We welcome you, Dr. Mahati Chittam. Would you go ahead first, Tejal? Should she go ahead first, or should we introduce everybody all together?
Please introduce all the panels so that that's out of the way, and then we...
Okay. Next, our second slide is Dr. Puneet Kempegowda. He is from UK, from United Kingdom, an academic clinical lecturer, specialist registrar in diabetes and endocrinology in the University of Birmingham, UK, and has a list of achievements and awards. It'll take a long time to read, but very, very exemplary and very impressive. A Teaching Achievement Award, the John Munro Medal for Teaching Excellence. A good teacher is always a good clinician too. And a good teacher, I know, makes everything complicated so simple. So it looks like he's been awarded a Best Teacher Award so many times. And a highly recommended and commended award on diabetes education. He is the Healthcare Professionals Award and has conducted programs. He's from the Royal College of Physicians, Lecture 2018 for West Midlands. A lot of, so many things on his resume, short resume over here. We'll pass on to the next person on our panel, and that is Dr. Deep Datta from good old New Delhi. Dr. Deep Datta is an endocrinologist and pediatric and adult, and he's a former assistant professor in RML Hospital. There's many publications. Research interests are from vitamin D, metabolism, and everything in endocrinology. I think off and on in Delhi, all of the endocrinologists here, we share a lot of common patients. You know, patients go from one doctor to another. So we've had some common patients. He's been a member of executive committee of the ISBMR, the Bone Mineral Research, Endocrine Society of India. He's a reviewer of major global diabetes and endocrinology journals. Welcome, Dr. Deep Datta. We have Rakhi Saha. Rakhi Saha, ma'am, is an MBA with specialization in human resources. She's Senior Director, Human Resources in Telco Production Company, and over 17 years experience of working in the IT industry. Very passionate about building partnering with businesses on talent management and performance needs. Believes in strong and being resilient, which every woman and every man should also be. Volunteers with many NGOs, and she will give her perspective of polycystic ovarian syndrome. And then we have another. Dr. Preeti. Dr. Preeti is an MD DM endocrinology. She's a professor of endocrinology in the prestigious SGPGI Lucknow. Many achievements and awards. As I said, this whole list of people over here are very inspiring. Several publications, invited us in many conferences, and we are waiting to hear your perspective on PCOS also, Dr. Preeti.
Thank you so much, Dr. Bhan. And I think that's our entire panel. I invite Dr. Chitra to please kind of take the proceedings forward. Dr. Chitra.
Thank you so much, Dr. Tejal. And may I now request the faculty to just click on the chat window and find a Google form there and take the next 2 to 3 minutes to fill it out. The audience who've joined in also should find the link in their chat window. I'm going to display the form here so that we can do this together. This is a quick, short reflection on how PCOS in clinical practice is for many of the physicians and gynecologists who've joined in here. So we begin with a question asking for your email ID so that we can get back to you if you're interested in joining hands for collaboration. We begin with asking how many patients you routinely see in your practice. There's a drop down here, and you can choose the number which comes close to the number of people that you see in a month. And the next question talks about, we all know that lifestyle modifications are a vital part of PCOS management. What do you think are the important components of holistic management of PCOS? Is it 1, nutritional modification, 2, exercise, 3, stress management, 4, sleep hygiene, 5, emotional well-being, and 6, all of the above? You can choose more than one option for this question. And the next question asks a difficult question. What percentage of people seeing you are able to successfully follow lifestyle modification? That's again a drop-down box, and choose a percentage which you think aligns with the results that you might find in your clinic. And then a question about the possible reasons that could contribute to poor adherence to lifestyle changes. Is it lack of adequate support from caregivers? Could it be financial constraints? Do you think it could be time constraints? Do you think it's lack of the understanding of the importance of lifestyle changes? Or could it be something else like mental health issues? Again, here you can choose more than one option. What percentage of people in your practice with PCOS have mental health issues related to PCOS? And again, it's a drop down, and give us a rough estimate of that proportion. And do you routinely ask people about PCOS, about mental health issues during the consultation? And do you think addressing mental health issues may improve compliance to lifestyle modifications? And how do you support people with PCOS for their emotional needs? While the audience fills out the form, I'm very aware of the fact that we are truly in a groundbreaking meeting. I think you can feel it in your bones when tides are changing, and I think this is one of those meetings. And I'm also very, very mindfully aware that we are in the AC AMMINI hall, and we're talking about a subject which is very close to our heart, and we're honoring a woman in endocrinology who did lots of work related to PCOS. And thank you so much, audience, for taking this time to fill out this for us. I'm going to stop sharing the screen. The link is still going to be active. Feel free to come back to fill it if you haven't been able to do that now. And my wonderful panel, thank you for being patient with us. I'm going to begin with Dr. Deep, beginning to ask you by asking you to reflect on your experience of caring for women with PCOS. I know you practice in Delhi, as Dr. Anjana has pointed out. How is it taking care of women with PCOS in your practice? Dr. Deep?
Hi, very good
afternoon. So very nice inputs by you, Dr. Chitra. I think as you've highlighted, it's a lot of problem. As endocrinologists also, we are not superhumans. Me myself have seen in myself also a lot of changes happening. I myself see I'm developing one or more features of metabolic syndrome. So as you said, it's in a busy OPD. And many times we do not focus on the psychosocial issues. We need to take time out. So what I have started doing nowadays is for the patients whom I need to give separate time, I keep a separate day of the week. Like Thursdays, typically in Dwarka, are the lightest of the OPD. So I give them separate appointments in the afternoon. Why don't have any other appointments? So, and many times I ask them, please come with your entire family. Don't come alone. Get your spouse along. Get your kids along. What I have noticed, if a lady has a metabolic syndrome, invariably her kids or the husband is also having metabolic syndrome. So we need to change the food habits of the house. We need to change the diet and lifestyle of the entire family. Just focusing on an individual, I think we are more likely to fail than succeed.
Right. Thanks, Dr. Deep. If I could bring Dr. Preeti to reflect on her experience of caring for women with PCOS. I know the clinical setup is completely different. You're in SGPGI, the OPD is busy and crazy. And also it's a different state. How has that experience been?
Thank you, Chitra. Maybe I think this is what I may say, something which may go down well. But the first and foremost is I think we need to change the name of the disease. It's no longer a cystic ovary disease, because half of the time is spent in trying to explain the patient and the mother that this is not the ovary, cyst in the ovaries, which is the major issue. And it becomes really difficult trying to explain to them the correlation of the metabolic problems, the infertility, and the psychosocial and obesity all together, which is so unrelated to the cystic ovaries. So if we did away with the name or had really a good name for this whole syndrome, half of the job would be done, which would explain them that it is much more beyond the cystic ovaries. And anyone who has an irregular cycle comes with an ultrasound. I'm sure all of us sitting here would be, or 90% of the patients do come with an ultrasound, which says PCOD, and that's it. Beyond that, then the family or the patient is not ready to listen to anything else. So that is a major deterrent for me. And as you said, that the kind of patients we get, because coming from Uttar Pradesh, coming from Lucknow, the affluent society is on eastern or is on the western side of Uttar Pradesh, which goes to Delhi predominantly. We don't get patients from western UP. We get patients predominantly from eastern UP, from the hilly areas of Uttar Pradesh, which are socioeconomically lesser affluent, or they are socioeconomically in the lower middle class. And since ours is a government institute, but a paying government institute, so we get normally the lower middle class and lower class of society. So it's their problems are predominantly the cystic ovaries and infertility. Right now, these are the two issues with which they predominantly come with. For them to explain metabolic syndrome and other aspects is a big challenge for making them understand that.
Okay, so the last time we had a discussion, you did talk about how the fact that the women who come into your clinic might not really be very willing to share all the concerns and their struggles during a visit.
Absolutely. Good you reminded me about that. Another thing which is very peculiar for maybe Uttar Pradesh is that women who come, they normally come with ye mera bhaiya hai, ye mera chacha hai. So you have to understand they are not actually bhaiya and chacha. They are people who have just come from the village because the father was busy or the real chacha was busy with some work. So anybody from the village living nearby is a bhaiya or a chacha who has accompanied the patient. So you can't actually ask them such personal details and other things in front of somebody who's unknown to them. So all that aspects has to be taken into consideration. You actually have to dig into the relationship of the attendants and the patient and then broach the other topics. And if on occasions we have had the in-laws and the husband side of people coming with the woman, so trying to explain all this infertility in front of a mother-in-law becomes very difficult. So you actually have to understand the relationship of the patient with the attendants, and then have a conversation.
Yes.
You just can't be straightforward with them.
Perfect.
It's
So
really
family
difficult.
dynamics as well plays a role,
Absolutely. It's really important. And in UP, it's extremely important to understand.
Perfect. Thank you for highlighting that point, Dr. Preeti. If I could bring in Rakhi Saha, thank you so much for joining with us. And she's joining us as a person living with PCOS, and she's been so brave and forthcoming in sharing her story, because we learn from there. We hope to move forward to do better. Thanks, Rakhi. So if you could reflect back on your journey of living with PCOS, how much of support did you find from all sources, doctors, dietitians, coaches, therapists, family, friends, caregivers, and what tools did you find along the way which helped you feel in charge or take control of the condition?
Yeah. Thank you, Dr. Chitra, and the entire forum for giving me this opportunity to present the perspective of someone who is living with this condition, and what kind of challenges or what kind of struggle we did go through. So before I talk about the support and all, I would like to talk about the issues that I faced when I realized that and then I realized I have PCOD. So for me, my periods were very regular. There was no issue with my periods. There were two issues that I was struggling with. One was obesity. And second, at the age of around 25, 26, I started having thick hair growth at my chin and neck area, which was very unusual. And being fair, those kind of hair growth kind of created a lot of self-image issue for me. And that's where I started wondering that what is wrong with me. And at that time, I'm not sure how it is now, but at that time, the misconception or the misinformation I had was that if you have PCOD, then it has to be related with irregular periods. Since my periods were irregular, I could not relate it to PCOD. I did not even know that I should see a endocrinologist. So during that time, you meet your elders, or you meet your friends, or you meet your friends' mothers and all those people. So instead of a support or a tool, what I usually used to get is an advice, okay? A free sort of an advice. And typically it used to be, or if I used to meet a general physician, it used to be lose weight, right? Do something and lose weight. What nobody was understanding is I was actually doing a lot to lose weight, but I was not able to, overcome that challenge. I had done everything that was available in terms of fad diets to sort of gym membership to, in fact, going hungry for days and all those things, but nothing was helping me. I used to see that my friends or my colleagues who used to do some diets or exercise with me, they were able to lose weight. Their progress was much more smoother and faster as compared to me, who used to have a lot of struggle. I was not aware that there was an underlying issue with this. And the other issue which I had was of dark hairs created a lot of emotional trauma for me, because I was not able to understand what is happening with me. Is it something that is related to my lifestyle? Is it something? So there were a lot of misconceptions. People used to tell me it is because you are of a marriage age and you are not getting married, and hence that is happening. There were a lot of misinformation. It also impacted my confidence to a lot of extent. I stopped going to social events. I started avoiding most of the meetings in my professional life and all. Somewhere it all started giving me a lot of mental stigma, as well as it kind of impacted my confidence in my life. My journey to this disease became more informative and inclusive when I met my current endocrinologist. And this was after 3 or 4 years of when I started developing the symptoms. For almost 3 or 4 years, my struggle was only with me. I was not able to share it with anyone. I was not able to understand what was happening. My current endocrinologist gave me an opportunity to, say all my issues, however minor they were, however major they were they related to my physiology or were they related to my mental well-being. she allowed me to talk about all of it. And the first thing she said after going through all of it is, I understand. And that was a big, big difference for me. Because before that, all the doctors I was meeting used to just tell me lose weight and everything will be fine. When she said that I understand, and then she gave me a confidence that, you know, this is something that is a syndrome and we need to work together to overcome this. It will not be a short journey. She made me prepared that it will be something that we will have to manage throughout the life. It will be something that will need a lot of efforts in terms of my own lifestyle changes, as well as being very, very regular in terms of my medicines and all. So she guided me across all of it. So when I met my current endocrinologist, then my journey became a lot more smoother and easier. A lot of I have met other people also who have PCOD. They typically straight away go for, when they have thick hair, they straight away go for a dermatologist or a laser treatment, right? What my doctor told me is, if you do that, it will just be temporary. Instead of that, first let's solve the underlying cause, and then you go for a laser treatment, which will be more lasting, more effective. And that's what happened with me. I underwent my treatment for almost 4 years. Due to some other factors, I could not immediately go for laser. But then when I went for laser treatment now, the effect is very, very good. So I felt that she was able to provide me the required support, the guidance, as well as, she was able to help me with going to other services, which played a very big role for my treatment.
Thanks, Rocky. In a way, you found an ally. You found a person to fight for you, with you, on your side.
Yeah.
And
I mean, she
very,
just
very
didn't give
valid.
me a tap, she just didn't write something on a prescription and told me to take it. She explained me everything, right from what it is, why it is, and the main thing, it is treatable. I mean, I had lost all my hope by then.
Right. Thank you. Thank you for all of that. Many valid points raised about how it can dent your self-confidence, which in turn might get in the way of seeking help. And also the fact that we give generic recommendations like lose weight, change your lifestyle, and not give specific actionable points to work on. Very valid points. To build on that, I'm going to bring in Dr. Puneet Kempegoda. We have been part of a large study that we've done over the last year to look at emotional well-being of women living with PCOS, both in the UK and in India. And Rakhi did bring that up, that there were many aspects of PCOS which adversely affected her emotional well-being. Dr. Puneet, could you share with us the major learnings from that survey?
Thank you very much, Chitra. Thank you, Tejal and Chitra, for the invite. It's a pleasure to be in this amazing forum. Before I start off, I must say I already learned a lot of new things, for example, from what Dr. Preeti said about being considerate of a family member being there who may not actually be a family member. And this adds an extra additional factor that we need to factor in. And also from what Rakhi said, it's not just about the disease, it's also of having an expert who understands and has empathy with the patients. As Chitra mentioned, my name is Punit. I'm a lecturer in the UK, and I have been collaborating with Chitra and Tejal over the last year and a bit, looking at emotional well-being of women with PCOS across the globe, with particular focus in UK and India. It started off as a simple community-based study, community-based survey, where we invited women with PCOS to complete a survey which had questionnaires on anxiety, depression, weight stigma, body dysmorphia, psychosexual dysfunction. Whilst there's a lot of work that's already gone out in scientific literature showing that there is an increased level of anxiety and depression, the prevalence that we got was a little bit disturbing. The work we did, we had over 1,000 women who completed the survey, out of which half of them were from India. And the prevalence was 60% had anxiety, 25% have depression, and about 10% have both anxiety and depression. Nearly 40% have body dysmorphic disorder, and the weight stigma scores are sky high throughout. We then adjusted this data to take out other influencing factors such as age, level of education, marital status, whether they had kids, the country of their birth, ethnicity. We adjusted for all of these factors, and we still found that women in India were at twice the risk of developing depression, 1.5 times the risk of developing anxiety compared to UK. On the flip side, women in the UK had twice the risk of developing body dysmorphic disorder. This actually opens up a whole new discussion. Firstly, whilst PCOS may have a same pathophysiology underneath causing the disease worldwide, the impact on the disease on social life varies from country to country. And that would suggest that whilst we have to have international guidelines in trying to homogenize the care, it needs to be further individualized based on the country of residence so we can address emotional well-being. We then further went on to do a systematic review to understand this a little bit more, especially from the body dysmorphic disorder and psychosexual function, to see if there is actually evidence to suggest this. And our team screened about 3,800 papers in scientific literature and included a systematic review of 53 papers. And the results were astounding. Psychosexual function is looked at in 6 domains. I'm not going to go into detail of all of them, but just to bring in, there is a significant difference in women with PCOS compared to those without PCOS, which affects their psychosexual well-being. But the stark differences we saw was in body dysmorphia. There was a risk of having higher dissatisfaction with physical appearance and greater importance placed on their appearance by women with PCOS compared to those without PCOS. Now, this is going to just get worse in the era of social media with Instagram and TikTok. So there is a huge emotional burden that we are sitting on. I appreciate what Raki also said. It's not just about informing that we have this problem, but we also need to start working on it, and we are already on the process for it. This is not going to be a overnight issue where we can just come up with solutions. It will take us time, and we will greatly appreciate all of your help, including our patients, to guide us how best we can go for this. This is going to be an area which has not been explored till now. Thank you, Chitra.
Thanks so much, Dr. Puneet. Very, maybe, let us say, difficult findings from that survey, right? If I can bring Professor Mahathi into the conversation. So we've been talking about how PCOS is a metabolic condition with reproductive manifestations, and Raki's been sharing with us the emotional struggles, and Puneet has shared the findings about the large burden. How does all of this add up? I mean, I'm a physician, right? Why should we now start paying attention to the emotional aspects of a condition?
Thank you for asking that question, because see, the thing that is very striking is, of course, Puneet, your study, and coupled with Raki's lived experience, and then Preeti's cultural context. So what's happened now is that we're encountering an India which is highly globalized, but still has very strong sociocultural values, around marriage and around, what's the right time to have children and the right number of children and all of that. So I mean, inevitably, I keep joking about it, and no offense to all doctors here, but doctors are a little like ASHA workers in India, in that they keep constantly having to upskill themselves. There's no break for doctors. So I can only understand many doctors being very unhappy about having to learn new communication skills and all that. But in the end of the day, there's a cultural expectation that doctor is God, right? So, I feel it's a physician's responsibility at once to debunk that doctor is God, just to protect your, your longevity, I suppose, in one sense. But also, it's important to understand that, when a patient walks in, and you already have said this, is that they come laden with so many emotional baggage, but that's all socioculturally driven. A lot of it is, driven by the fact that they need to be accepted. So yeah, so doctors need to respond to the emotional angle also because, when a person is heard, right, then they can start focusing on their well-being. Because otherwise it's like a circle that hasn't closed, and they're constantly looking for someone to help close it for them. And if it doesn't close, whatever you're saying is going to bounce off of them, right? So unless somebody says, I know this is really hard, or if someone can say that, I don't know what it's like, but I can imagine that, not being able to get married or having more hair than usual on your face is hard, that helps close the cycle. So that's something that, it's important to appreciate, that a lot of times doctors think that empathy is about feeling like you walked in their shoes, but it's not necessarily that. It's about expressing sensitivity. And when that is done, then half the journey for a patient is also done. So I think, Dr. Preeti, you were saying that, right? Like being an ally to the patient, that is what they crave because they don't get it in the outside world. So I'll stop at this point so that, you can go on, Chitra.
So Dr. Mathi broke it down very, very, very well for us. So we don't need to know exactly how to deal through the entire complexity of the emotional wellness. It would just be okay to just listen and then say, okay, and then be the ally that Rakhi spoke about, who she's finding in her current endocrinologist, whose name I'm terribly tempted to leak out, but I'm not going to. So I'm going to bring in Dr. Tejal to talk about. So Rakhi did also tell us stories about how she thought it was not PCOS because she had regular cycles. Also about the fact somebody told her that the increased hair growth was probably because she was not married by that age, right? So do you think that women have access to a reliable, accurate source of information about PCOS?
Thank you, Dr. Chitra. And the first thing that I would like to say is that I think we have this habit of unintentionally confusing our patients. All of us don't have time in the clinic, so we aren't really able to go into the depths of the communication that probably we should be going. Pathophysiology, impact on fertility, impact on metabolism, long-term outcomes. But we also tell our patients often, please don't Google because it will make you more anxious and it may throw up things which are not really true. Right. So it's a catch-22 situation. We don't have time to give the full information, but we also don't want them to find out information on their own. And I think that accessing the internet is not something that we can control. It's just not an option anymore. So I think that instead of passing the buck, it's time that we took a stand. And I think that it's our responsibility to maybe come up with a resource which is very socio-culturally sensitive for our country, which provides the information to our patients so that they can make better choices for their health. And it has to be information which is scientific, ethical, but in simple language, so that the person can comprehend without really mudding it up with medical jargon, because that's what we all hide behind. I think as doctors, we love our medical jargon. But if you could break it down in simple, easy to understand language, having a resource which is specific for our country, I think will be a very big step forward. So I dream this, and I pray that it comes to fruition, that there is maybe 6 months, a year down the line, we have a resource where anybody treating a person with PCOS anywhere in the country shares a link with the patient and says, you know what, if you need more information, please access this site and this will give you the right information. Come back, let's talk about your doubts, let's discuss what is not clear, and then we take it forward. So this is a win-win situation. We save time for the more urgent and the more confusion and the things that we need to sort, but also that we empower our patients to take to make their own choices. Caregivers can access the site, friends, relatives, everybody can access the site, and we all have enough information. So Dr. Chitra and I, this is our dream, and we hope that in the next 6 months to 1 year, with the help of gynecologists, endocrinologists, dermatologists, nutritionists from across the country, we'd be able to make this dream come true.
Yes, more power to that dream, Dr. Tejal. So I'm going to bring in Raki here, and I'm going to switch gears a little bit. And now I'm going to ask you to dream about your ideal PCS consultation. What would you have liked your 20-year-old self to find when you walked in looking for help?
Yeah. So I think, Dr. Chitra, much has been said about having empathy and understanding of patient condition. But there is one thing I particularly want to highlight is the endocrinologist or gynecologist or the physicians who are treating the PCOD patients. In the first phase, it is very, very important that they help the patient to accept the situation. Okay. Because in our culture and in our this thing, me having something is like treated as a very negative point, right? So the first and foremost hurdle the patient needs to cross is, or at least I try to cross is accepting that yes, it is the situation. Once you accept the situation, then it is easier to trust on the doctor, because the doctor has helped you understand the underlying reason very, very well, and it has helped you to accept the situation. Then it becomes much more easier to trust the doctor, to follow the advice, and work towards recovering from it, right? So I feel the physicians should have this kind of an approach, but it also need additional disciplines to come in, basically like counseling. And the counseling should not restrict only to the patient. It is very, very important that the counseling extends at least to the parents, especially the mother, because they typically have this thing about the daughter's marriage, and this misconception that because one has a PCOD, there will be a fertility issue and all that, so they kind of try to get their daughters marry early, or they don't kind of focus on what the treatment is, and instead of that they focus on the social pressures, right? So a counseling to the parents is also equally important. If the person is married, then maybe husband, but in then second thing is, during my PCOD journey with my struggle with obesity, I met a lot of dietitians. I mean, I have spent money on VLCC, Nutralife, God knows what all. But what later on I understood, it is not one size fit all solution for us, right? So if there can be a specialized nutritionist who understand that for us it is not easy to lose weight. For us, we will fall off the wagon multiple times, because ultimately it is frustrating. You follow diet, you follow exercise, but you're not losing weight. So that nutritionist also needs to understand the psychology of us going through this. Just giving the diet and just telling us to follow it by the T. Although we do that, there is no trust on us. आपने ही कुछ गड़बड़ किया होगा. You must have had broken your diet somewhere, or you must have not followed your exercise. Those kind of comments hurt. They actually hurt, right? So apart from that, yes, the other major thing is, because I faced a lot of issues with thick hair. I mean, I never tried to go to a dermatologist immediately, much thanks to my endocrinologist. But I see that there are a lot of ads, there are a lot of institutes which offer laser treatment. It is very attractive, that take 5 sittings and your hairs will be all gone. But what nobody understands is that is more of a cosmetic thing, but not a medicinal thing that is helping you. So our dermatologists also need to understand that, if a patient is coming without being treated for PCOD, just doing the laser is not going to help. And I may be using wrong terms here. What I meant by dermatologists is most of the skin institutes and all who just treat the superficial issue, but the hair will come back. So I feel these are the 5 or 6 streams which, if come together, will be a very holistic way of helping the patient to deal with this issue.
Very, very valid points, Raki. Thank you for that. And I'm going to bring Dr. Puneet to comment on that a little later. But before that, if I could just get Dr. Deep to reflect on, Dr. Deep, we've studied long and hard, and we did DM for 3 years, and we learned all about insulin resistance and HOMA-IR. And suddenly we are talking here about how we should pay attention.
Chitra?
Yes, sir.
Hi, before Deep comes, I would like to say Raki raised a very important point, because PCOS is a multi-speciality issue.
Right.
At different stages of life, they have to resort to different types of clinicians. And sometimes the other clinician is not aware that the patient is following one specialist. So what we have actually planned, we have done at our institute and one more institute in Mumbai through ICMR. We have suggested to the government that we should have a PCOS station, a multidisciplinary clinic where it is housed by a dermatologist, endocrinologist, gynecologist, a psychiatrist, and sometimes a radiologist also there. So we have started this model in our institute. We have a multi-specialty clinic once a week. So these patients go through all the clinicians and get a one-stop sort of advice. So if that is a sort of a way can be done by other clinicians, it will be very nice for patients. That is what Raki was trying to say. Thank you.
Thank you, Dr. Ashraf, for sharing your experience of attempting to bring in multidisciplinary approach for peace, because it looks like we do need more than just the endocrinologist to provide holistic care. Dr. Deep, so can you share with us, as a physician who's been trained to talk about metabolism, and now we are suddenly asking of doctors to pay attention to emotional well-being, is that asking too much of an endocrinologist? We are already busy. Do you think this is something we can imagine ourselves evolving into, changing over the next few years? Or is this just too much to ask?
No, absolutely not. It is not just too much. I think we shouldn't just restrict ourselves to PCOS, as I said previously also. It's a part of the metabolic syndrome, and stress, psychosocial aspects are a part of all non-communicable diseases. So just to treat the numbers, just to treat the hormone parameters or the lipid profiles or the HbA1c or the total testosterone level is not going to work. We need to look behind the psychosocial precipitant factors. Unless we address them, our medical therapy is not going to work optimally. It is going to cause a lot of dissatisfaction on the part of not only the patient, but also the treating physician. So, and that ends up in switching a lot of physicians also, and it becomes a vicious cycle with an unhappy ending. So we need to give time, invest time. I agree with Dr. Ghani that we should have a team-based approach. There's a lot of myths also. Many times we end up over-investigating. A lot of unnecessary biochemical tests and hormone tests have been done. So we tend to run after numbers. I think we should treat the person as an individual and not treat the numbers.
Perfect. Thank you, Dr. Deep. I'm going to bring Dr. Preeti into weigh in, okay? And Dr. Preeti practices in Lucknow, which she highlighted was a paying government setup. But we've all studied even in government setups, which is non-paying, where OPDs run with 400 to 600 people on a daily basis. I'm just going to ask you now, do you think all of this entire conversation is something which might be relevant to a subsection of the society, the urban upper middle class, India, or is this a conversation which remains relevant in the rural setting, in the government setting? Is it a feasible thing at all to reflect on?
I think it's relevant to all sections of society. Maybe the content may vary, as I brought out that in rural India, it may be more to do with fertility. They're not so much concerned about if they have minimal hirsutism. I have seen youngsters being very comfortable with it. Even college going students, I have hair, doesn't matter. I've been like this. How do I care? So these kind of extremes also I have seen. So first and foremost, we really need to understand, and maybe we really have to spend time on our first interaction with the patient is what kind of a problem the patient has vis-a-vis the manifestation of PCOS, and then bring out the socioeconomic and cultural aspects, and then talk about the emotional, how it's going to help. So I think the first consultation is the most important one, where you want to bring out all these things when you're suspecting that the patient has polycystic ovary syndrome. And the urban population is, as you said, that it's relevant, but even in the rural setting, it is equally important. And we lament about the lack of good clinical psychologists in B-tier cities like ours. You really need a good psychologist, and we really lament about the lack of trained psychologists in small towns.
And also maybe as physicians to, while we have our list of priorities of making sure we prevent diabetes, making sure we prepare for not getting GDM, we should also maybe factor in of all these many manifestations, which is the one which is most hurtful to you, most important for us to address, right?
Absolutely.
Maybe just factor that in, because for us, mild hirsutism might be devastating for her,
yes,
as Raki told us. I think that's an important thing to bear in mind. I'm going to bring in Dr. Puneet. We've spoken a little bit about multidisciplinary approach, and I know that you have a holistic multidisciplinary care in NHS at the university. Share with us the stories so that we can learn from that and try and implement that moving forward.
Okay, Chitra, it's humbling to hear you want to learn from me. It's actually the other way around. I've been learning a lot from you and our patients. Chitra, you very well know how I work. All my research, all my clinic practice has always been patient-driven. We go to the patients and ask them, what do you want us to do? And that's exactly what we have done. We have not started off with a question, what we want to answer. We've always gone to them. It's very interesting to hear Dr. Ashraf, Professor Ashraf Ghani's points, and also Deep's point. And all of them make a very valid point. Whilst it's a multidisciplinary condition, and it means, which means that women will benefit having all of this care, Ashraf made a very important point. They may not need all these consultants all the time throughout their life. There are times when it is important. And this actually brings up to our recent study where we have done called PCOS Pulse, where we explored the lived experiences of women with PCOS across the lifetime. And it clearly shows there is a pattern based on which certain women need certain particular types of support throughout. But long story short, again, Chitra, Tejal and I have been involved in this newer system using the available resources to try and improve the patient care. What we have done now here is any person who comes into our services, both in UK and in Bangalore and Mumbai, with a suspected PCOS, completes a survey, a preclinic survey, which includes their socio-demographic concerns, which gives us an idea of where they come from, but also completes a questionnaire on anxiety, depression, weight stigma, body dysmorphia, psychosexual function. And what this does for them is two things. One, it starts triggering the mind, saying that, okay, when they answer the questions, it starts putting to the mind, what's this questions about? So they start thinking about it. But at the same time, it's information gathering for us, because we know that when a person comes in, when we have about 20 minutes consultation, we know what to prioritize. Once they finish the clinic, they also complete a second survey called a post-clinic survey. Again, has 3 parts to it. First part is what was the experience in the clinic. And this is a feedback system, i.e. it tells us in real time what was the patient's experience and how we can improve this further. The second part is about what information did they receive about non-pharmacological treatment. And I very much agree that it becomes overwhelming for a single consultant or for a single consultation to provide all the information. So that will help us identify what was the gap in the knowledge and experiences. And the third part is to understand what did they take home and what was the concerns that's still left. So we then, when we go back to the next consultation, we'll be able to address them. What this has done, and we've got about 120, 130 women already recruited now, and we are already reviewing the interim data. It's given us a feed-forward system. So we now have already revised the way we are providing care for women with PCOS. We are able to further streamline how we are reviewing in their follow-up clinics. And it also gives us an opportunity to explore what is the burden of disease that's out there. Now, with that said, I don't know if I can share a screen. If I can, I would like to share one slide, just one slide if it's possible. Is it possible for me to share?
Yes, yes, of course.
Yes.
Thank you.
I will just see if I need to make you co-host.
But that's a great
Can
point.
that be done? Mintu, someone from the IT team, can they
It's
share the screen?
it's okay if it's too much of a hassle,
No,
but I
it's
just wanted to
not.
show.
Just try if you can. I am also not very. Just try to share the screen.
Yes, I can. Yes, I can. Thank you. So all I wanted to share was this one slide. It looks very crowded, but it isn't. It says this is how we follow for women with PCOS. Any person who comes into our clinic, we first screen them to see if they're eligible for any of the trials we are having. We've got loads of clinical trials going on. We have DAISY PCOS, Levinoxo, PCOS Seva, Blue Morpho, PCOS Pulse. We screen them. If they're eligible, they go through the research process. If they're not eligible, they still go through the process. And at any point in time, if they feel eligible, they'll be brought down, and still they will be given a unique ID, which is what Chitrami and Tejal are doing. All these women are discussed in an MDT. And this is important because, again, as I said, we need to understand that we can't put in a additional burden for women with PCOS. We can't ask them to go see 5 or 6 clinics in one time, but we will be able to address and see what they need. And then we direct them to appropriate clinic, either a skin clinic, fertility clinic, or the discharge. This is NHS-based services, but this is one. And then any person who comes into the clinics, they all get, this is the system that we are following at the moment with Chitra. This gets screening, we call them, we recruit them, they complete a survey, loads are going on. I'll stop my slides here. There's plenty of pathways that we have created, but the main reason why I want to share this was, this is not how it started. And this continuously refined. This is a very different kind of piece of work that's done, where you have a piece of research. The traditional one is you have a piece of protocol and you stick to it. We don't. Chitra and Tejal always make fun of this, saying that you change the guidelines all the time, you change the system all the time. But that's how it is. We drive our care based on what patient wants. What they may need 6 months ago is what they may not need now. And that's how we change. And that's the system that probably we will be looking forward in the future. It has to be a feed-forward system and a feedback system built into it. But yes, so to go back to what Chitra asked, there is no one system that we are following. We have a system that's continuously evolving, and that will further evolve as we speak. And before I end, I'll just mention one thing, what Chitra mentioned, what Tejal mentioned, that we can't, and I agree with you, we can't tell patients not to access internet, but we can guide them where they can find evidence-based resources. And we are now working on this with the help of Chitra and Tejal. We have built in what we call as Comics Lite, which has simplified information about PCOS and various different aspects aimed at patients. But we also have a counterpart called Comics, which has the same information helping clinicians. And all of these are like 2 to 5 minutes, so they don't need to invest too much time, energy, at the same time grasp the concepts. This may not change the way they think about PCOS, but it starts triggering lights in the brain, making them aware. And the whole idea is the eye can't see what the mind doesn't know. The moment you make them aware of this, they start thinking about those things. Thank you, Chitra.
Beautiful, Puneet. I think takeaway points for busy clinicians could be that we could just have a QR code with a survey asking them about their 1 or 2 questionnaires about their emotional well-being, and also maybe a post survey, just like we did a pre-session questionnaire, and then maybe a post survey, what they would have liked it to be different, and we can all evolve and improve, because all said and done, PCOS is a new condition. We learned it in an entirely different setup, and we are practicing it in an extremely demanding setup, and nobody taught us how to evolve and learn from the current scenario. Thanks so much, Dr. Puneet. I'm going to bring Dr. Marti, and I'm going to ask you 2 questions, Dr. Marti. Dr. Ashraf told us about the PCOS station with a psychiatrist. Please tell me the psychiatrist's role and a psychologist or a therapist's role, and how do you think that bringing therapists onto this will improve outcomes for women living with PCOS? How will it help doctors?
Very good questions. So the first one, psychiatrist versus a psychologist or a therapist, right? So psychiatrists, as everyone knows, are the ones who can prescribe medication. And my range of prescribing medication is Calpol for my children, right? So obviously I'm restricted. So mainly the difference is that a psychiatrist uses a medical approach to patients, and a psychologist is a mental health therapist, right? As a mental health professional. Often psychologists will have a master's in the minimum, and more preferably a PhD. they deal with mental health issues and also less severe symptoms. So the bulk of us will experience anxiety, yes, but it doesn't necessarily have to be severe anxiety that requires medical management. So fundamentally, then, a psychologist uses a more therapeutic approach to care. And so with that comes the opportunity to approach a patient more holistically, I guess, or in a more wider, non-medical fabric. So, so that's mainly the difference. And so I strongly advocate for groups that have an inclination towards psychiatrists, or at least the inclination to hire somebody in that domain, to actually hire a psychologist rather than the psychiatrist, only because physicians, a lot of you know how to prescribe basic medication for sleep and so on, and offer referrals to psychiatrists. But having a psychologist on the board is actually having, reducing the amount of upskilling that you need to do for yourself, because a lot of it can be, you can ask, the psychologist to deal with. Now, the second part of your question, right? So what can a psychologist do? And this has been a question I've been answering since the last 20 years of my career. And I feel like, it's really important to advocate, but at one point I wish I don't need to advocate. One is that they can definitely help with family discussions. So like what Dr. Preeti was doing, right? To kind of assess, is that cha-cha really a cha-cha? And so these kind of things are stuff that psychologists can really easily help with. We are trained to understand these kind of complex relationships, complex cultural milieu, complex social underpinnings of any kind of context. So psychologists can bring in family, and facilitate family discussions. They can facilitate, goal setting and behavioral change. So, behavioral change should not at all be placed on a doctor's shoulders. It is not their expertise. They should not be doing it. And I don't know, I know that it takes a lot of gall to say this in front of a room full of doctors, but I genuinely think that, sorry?
Please say that again. Please say that again.
So, yeah, you know what? If Tejal and Chitra call me, it's because they know that I have zero filter. But it is so important for doctors to understand that, counseling, that is not their expertise. So I don't understand why a physician would want to kind of have that expertise, because then you'd have to study as much as you had already studied, to get to that point. But that's what a psychologist is meant to do. So goal setting, for example, none of us can do with big goals, right? So a doc says, manage your diet. But, the everyday aspect of managing that diet is something that a psychologist can help with, a nutritionist, with a physician. So goal setting, behavioral change, family discussions, support groups, these are the things that a psychologist can bring to the board. But apart from that, and I think it's really important to focus on this, is that psychologists can also bring in, and at least I train psychologists and groups on this, is they can help with self-compassion and self-acceptance, not only for the patients, but also for the doctors. Because often what happens is the doctors come all burnt out every day, right? So look at us working on a Sunday. So, I feel that a psychologist, and I do this with any consultancy work that I do, any group of doctors who come to me, Tejal and Chitra have also, been subjected to this, business of self-acceptance. Okay. And it's important because, a thematic I hear in today's conversation, and even in the previous session, is how difficult it is to keep on exhibiting resilience. And with this focus on being resilient all the time, it's not that easy. So it's important to forgive. So like Rakhi was saying, right, you slip up, you keep slipping up. And it's so important to forgive yourself for it. And it's so important for a doctor to forgive themselves, because doctors also come with a problem solving, the entire curricula is for you to solve a problem, right? But this is not a problem that you can solve all the time. So how about just cutting yourself some slack, right? And saying, this is very difficult. And we'll do what we can, and that's okay, So I think that's what psychologists can bring to the board. And so thank you very much, Chitra, for giving me the opportunity to add what you said.
Chitra, can I just quickly come in with a question for Mahati in 1 second?
Go for it. Go for it.
Can you differentiate what is counseling versus what is active listening, empathy, and sensitivity? Is there a difference between this? So I think as doctors, we can do active listening, exhibit sensitivity, but we can't counsel. Am I correct about this?
Yeah, I agree that I mean, counseling is again, falls within the purview of a psychologist. Active listening, empathy, sensitivity training, these are things that doctors should learn, and it's so important. So that's why I was saying, right, in the earlier segment that, it's important for a doctor to say, I understand this is really hard, but here's Dr. Mahati, go talk to her about the rest of it. Jokes apart, but yeah, it's important to kind of actively listen and all that, but counseling requires dedicated, focused attention on the emotional journey, the psychological journey that the individual or that family is going through. So there are theories, there are therapies that are all part of the counseling part of it, right? So I find it very problematic. I'm sorry that doctors say we have to counsel the patient.
I disagree there. One second. So there are, so number one, can I pitch in right now, or are there some rounds? Because I think I'll just try to kind of put it somewhere, and then Chitra, you can take over.
Yes.
So I really like the conversation, and I completely agree with you, Marty, but just a point there. The problem is, so to bring in all of this, because you quoted a study where most women had mental health who presented with PCOS. So by definition, PCOS is a visible cosmetic problem because of which girls present to us. They will not come to us for their metabolic issues because that's how it is. It is a visible weight gain, it is a visible hair growth and visible impact on them, either because of them or because of the social norms set around how the girl should look like. So it is ultimately presented because of psychosocial issues, and all girls with PCOS just come to us just to talk to us. And there is no way we cannot counsel, and there is hardly a few percentage of them who would agree to go and talk to a psychologist. So that's the fact. That's the fact of the matter. So we end up learning how to counsel, even if it's whatever half-cooked way. But that's how PCOS clinic goes. All my PCOS clinic is just psychological thing. There is hardly much discussion on other things. They're not ready. They don't come to the stage where they are ready to just absorb information. They have come here because people are looking at their weight, because people are looking at their hair. And half the time I'm telling them that you look good. You don't need to lose weight. You don't need to remove hair unless you want to. So just giving them that thing that it's your choice, not pushing the therapy, because half the time the therapy is to tell them that you have to look this way. And that is something which I think needs to be addressed. Chitra, if you can take this point also, do they always need to get their hair cleaned up? Do they always need to get their weight brought down? Are we just reconfirming, establishing the social norms which actually results in psychological issues? Or are we going to also address that why this girl is coming to my clinic? So the first question I ask them, why have you come here? Why do you want to look a certain way? So that's my first question. So Chitra, please. And if we can wrap up after that, because I think we are
absolutely. Chitra, can I close this? So, Dr. Beena, the problem is that you are the exception, not the norm. What you do in your clinic, the time that you give your patients, I'm talking about an endocrinologist to see 60 patients a day. This is just not possible. So I greatly appreciate what you're saying. And in an ideal world, yes, all of us, I wish we could practice like this. But when we can't, then we have to give the option of a psychologist. And I do refer many of my patients consistently to a psychologist. They do seek help and they have great turnarounds in their life. So I think that it's a compliment that you are doing a great job with your people with PCOS, but not everybody can replicate that same care.
No, when I speak, I am speaking on behalf of most endocrinologists, because I think that's how we are trained. Dr. Preeti is here. I have been trained under her, and I know how all of us are trained.
But I want to just cut in for 1 minute.
Yeah, please.
I completely agree with you. And this is the reason why I was saying it is not fair that you should do the counseling. It is just not fair, because you become such a good doctor that you will never have time to breathe because you have so many people knocking on your door.
But I think we may have to select that these are the cases where we really need to push them to a psychologist because it involves certain amount of money, and they're again becoming comfortable with someone else. And plus give us some tools so that we can handle most of the other women. I mean, I'm just saying that after all, it's a conversation like we talk
Yes,
to
exactly. There are some people who need, so what I say that.
Sorry, Dr. Sheila, we are stretching over. I am trying to close, but I am prolonging.
No, Beena, that's a fantastic discussion. I really am not, I didn't log in to close it. I just logged in to say it's
I'll ask Dr. Preeti and Dr.
into a psychologist. That's all I wanted to say. Please continue. I'm enjoying the discussion. I'm learning a lot. So I didn't log in for that. I just logged in to make a point that I understand what Tejal and what Mahati is saying, but it's not easy. Practically, is it easy? My patients look at me aghast, Tejal. They will say, "Madam,
No.
वो नाराज हो जाते हैं.
Dr. Usha made a point. Dr. Usha, do you want to come in with your thoughts? She said the scale of the, ma'am, please go ahead. Ma'am, you're muted. Dr. Usha, you're muted.
So Sunday afternoon actually well spent. So great discussion. Thank you so much. Just want to say just two things. PCOS, it's not a monolith. So there is all kinds of women coming in with different problems. So some, it's this that come in for menstrual irregularities or for hair growth, which we may be able to tell them it's a cosmetic issue and don't worry about it. So, and then there are others who have a ton of other things that may have bubbled up or still stay inside. But one last thing I want to say is that we need a program to have message discipline among doctors, because the same PCOS patient goes to 10 doctors, they hear 10 different things. So unless we are able to tell them the same thing, where is this problem coming from? What are the components of it? What can it do to you in your life? What can you do about it? It's not a one-off, one-time thing. And what is the long-term consequences? And, so many different things. So I think that training, we need training, and I think we can take that up as a program.
Thank you, ma'am. So, Dr. Chitra, any last words? I'm just going to quickly close with.
You go ahead.
Okay, so I will try to join all the dots. So the question that Chitra was going to ask me is what is my vision for the evolution of comprehensive care in PCOS for our country? I think that the kind of fragmented healthcare landscape that exists in our country currently, and the day that we will have uniform healthcare, I think is a day which is, I don't know when it will come. But in the meanwhile, what I think that could be an answer to whatever we are talking about, I like what Dr. Preeti said. There is a need for psychologists, but they're not available in tier 2 cities, correct? Raki spoke that she sees a need for nutritionists who are specialized in PCOS care. So I think that the COVID pandemic has given us this great gift. I think the great gift is the acceptance of telehealth and digital therapeutics. And I think that digital therapeutics can possibly provide the answer to put all of this together. See, there are two main issues: affordability and availability. And having a digital therapeutic platform, which is led by a physician, but also has a multidisciplinary team with nutritionists, psychologists, physiotherapists, care managers all together on board, which makes it affordable and available wherever you are in the country. It can be customized to regional and local languages. It not only gives the information that people need to take care of their PCOS, gives them the ways to lose weight, how to exercise, how to manage their mental health. And I think that all of this, when it is led by an endocrinologist or a gynecologist or a physician who cares for people for PCOS, this is where I think, and I dream as I always am, that this is the way forward. Dr. Sheila and Dr. Beena, in my practice, I consistently refer girls with PCOS with psychologists when I explain of how what they're experiencing is not unusual, but they could do better if there was somebody who focused entirely on their emotional journey and helped them kind of, deal with it in a good way. There isn't that much resistance. So maybe the resistance could be to a certain extent in our own minds. We assume that people will throw us out if we talk about a psychologist. Because this is the AC AMMINI hall, I will close with this anecdote. Dr. AMMINI was my DM examiner, and Dr. Anurag Leela and I were the candidates. And both Anurag and I, throughout the exam, kept saying, we will counsel our patients. And the entire exam was over. We both passed. And then Dr. AMMINI sat us down and said, hello, children. You do not counsel your patients because you are not certified, experienced, or taught to counsel patients. That's not your job. So this is what Dr. AMMINI closed my DM final exam with. He said, your job is to educate the patient, inform the patient, empower the patient, but you are not trained to counsel patients, and you need to send them to the appropriate specialist to be able to be counseled. I will close here. Thank you for the wonderful opportunity, Dr. Chitra. There was a wonderful panel discussion. Thanks, Dr. Mahati, Dr. Puneet, Rakhi, Dr. Preeti, all of you for being here today and sharing your wisdom. And we give the floor back to Dr. Shaila.
Thank you very much. That was a really intense discussion. And as I said, I learned a lot. I think this would take another...
Thank you everyone for being here. Yeah.
I think it will take another 2 to 3 hours or maybe more for us to really agree. Until then, we can agree to disagree.
Yes, yes. I was purposely being disagreeable there. Sorry.
Otherwise, it will become, otherwise we won't move forward. If we agree on everything, then there's going to be no science left. So I think it is perfect to disagree, to be very honest. I'm going to ask Beena to convey her vote of thanks. It's been a fantastic 2 days. It's been an awesome journey of learning before we did the meeting. And so now I'm going to give it over to Beena, and she's going to convey the vote of thanks. Over to you, Beena.
All these form things. So I
Beena, we can't hear you.
Say that discuss today. Hello, can you hear me now?
Yeah,
I think. Shall you go ahead? Yeah, okay. Thank you everyone for being here on a Sunday morning. It didn't feel like we are having a serious discussion, and this was like the best discussion we had at the end. We are leaving so many questions in the air, lingering there, because I am sure what Tejal and Chitra are going to do and what Dr. Preeti is doing at SGP now, and each of us in our, going to take these questions and structures which we have. We know we similarly all the previous conversations being a part of WeCare, and we hope to come back again with a better discussion, better presentation next year. Thank you, everyone.
Everybody, thanks for being the fantastic team that we all are. Thank you.
Thank you. Thank you.
Thank you, everyone.
Thank you.
Thank you.